Kodwa manje ngiyazikhulula goyo, ngifuna ukukhaphela ngaphandle kokwesaba, ngiphumulele kudezelweni. ngaphandle kwemithwalo ndala.
Is the team with abstract number Aphpn 2025-019. That's Dr. Alero Chimauduko et al. So that's third position. Okay, so the team in the second position. So the second position was 2. The team with abstract number Aphpn 2025-025. And the team is Dr. Rotimi Jayesimi et al., presented by Dr. Alex Oko. And for the posters, still, the team with the best poster across board, after taking the mean for all of the judges' assessments, the team is the team with abstract number Aphpn 2025-009. Dr. Damilola Akinlaon et al. Okay, so don't worry, it's not mago. It was based on what the judges assessed. Completely based on what they assessed. Right, so that was the poster. So we go to the oral. So the oral one, the oral presentations were also keenly contested. And after summing up the scores and taking the average score, we have for oral presentations, the team in third position is the team with abstract number Aphpn 2025-018, Dr. A. Alero Chimauduka et al. Okay, so that's the same team that also won a prize in the poster. Then the team in the second position is the team with abstract number Aphpn 2025-010, Dr. Glory Fua et al. And the best oral presentation I had that is in the first position is the team with abstract number Aphpn 2025-024. The team presented by the oral presentation made by Dr. Bisola Adebayo et al. Thank you very much. Thank you very much. And they will get their awards later. Thank you.
Thank you so much, Prof. Please, another round of applause for all the presenters yesterday. They did an amazing job. It's not easy to stand and present or do a poster. We move right ahead to the next item for today. We're going into a presentation session followed by a panel session. I will be calling on one of our senior doctors, mamas, and in the person of Professor Odemi to give an overview of this session as well as welcome the speakers. So please join me as I invite Professor Odemi to the podium. A better round of applause, please.
Good morning, the chairman of Lagos State Aphpn chapter, all our very, very distinguished members of Aphpn that are here bright and early today, ladies and gentlemen, good morning. It's a privilege to welcome you here today on day 2 of our very important conference, and also to welcome you specially to the first session of today. And this is a very special session with the sub-theme, Rethinking Health Sector Investments, a call for a paradigm shift towards equitable and sustainable approaches. This sub-theme explores a topic that lies at the very heart of Nigeria's quest for a stronger, fairer, and more resilient health system. Across the world, health systems that have acquired measurable progress in access, equity, and quality have done so because they embraced intentional, well-structured, and sustainable investments. And these are investments not only in infrastructure, but also in people, in financing mechanisms, in technology, and governance models. As we all know, Nigeria continues to face major public health challenges, such as inequitable distribution of quality care, catastrophic out-of-pocket spending, poor financial protection for the vulnerable households, and also very insufficient coordination between the public and private health sector. And these challenges highlight the fact that our current investment models are no longer adequate for the epidemiological realities we face and for the health needs of our teeming population. We definitely have made a lot of progress in the right direction, but you will agree with me that we still have a lot to do to achieve appropriate health financing and coverage that we desire and we deserve as a nation. So that is what this sub-theme is going to focus on. We are highlighting the fact that it's time for us to make that shift from a fragmented, reactive financing towards equitable, inclusive, and proactive, sustainable health sector investment strategies that are capable of driving universal health coverage. And that is what will be the focus of all our discussions in this session. And today, we are very fortunate to have a very distinguished lineup of speakers, each of them unique in their own way because they are representing different but essential dimensions of health financing ecosystem in Nigeria. We are going to have this session in two parts. First of all, we have three speakers who are going to make presentations. And then after that, we are going to follow it with a panel discussion. So our first speaker will be today the Permanent Secretary of the Lagos State Health Management Agency, LASHMA, in charge of the Lagos State Health Insurance Scheme, and a central figure in advancing state-level health financing reforms. Her insights will shed light on how government-led insurance schemes are expanding coverage, protecting families from financial hardship, and strengthening public health outcomes through improved access and equity. We are also honored here today to have as a speaker the Chief Operating Officer of AXA Mansard, an HMO that is a major player in the private health insurance landscape. The private sector finances a significant proportion of healthcare in Nigeria, and HMOs occupy a strategic position in risk pooling, claims management, provider accountability, and innovations that support cost-effective service delivery. So her perspective is very important in this discussion, and it will help us explore how private insurance can collaborate with public schemes to drive efficiency, expand choice, and improve user experience. Our third speaker is the Country Director of Farmer Access, who is going to be ably represented here by Mr. Sunday Ngbejime. And he brings a global perspective rooted in decades of work, improving health financing, digital innovations, and facility quality care across Africa. Farmer Access has played a critical role in enabling financing models, digital financial inclusions, and safe care quality improvement framework. His contributions will illuminate how international partnerships can catalyze sustainable investments and strengthen our local systems. Following the presentations by these three very eminent speakers, we will then transition into a panel discussion to broaden the conversation on this very important topic further. And for the panel discussion, our three speakers will be joined by two other people. They'll be joined by the National President of the Association of Nigeria Private Medicine Practitioners, whose constituency provides frontline care for millions of Nigerians. Therefore, his perspective is very critical in this discussion. The panel will also include a patient who has been involved in a health insurance program. You agree with me that we should also hear from those that matter most, the users. And so he's going to also join the panel discussion to give us his own life experiences. The strength of this session is therefore that it brings together the government. We have someone from the government, bringing them together with the private sector, the global partners, the healthcare providers, and of course, the patients themselves. So we have the full ecosystem required here today to reimagine what health sector investments should look like. And I hope that today's dialogue will spur us all into action and move us to innovative, inclusive, and people-centered financing approaches that can help us reshape the future of health in Nigeria. Thank you very much. So, MC, okay, let me introduce the first speaker. All right. So we go on to our presentations, and our first speaker today is going to be from LASHMA. We have with us the Permanent Secretary of Lagos State Health Management Agency, Dr. Emanuela Zamba, who I'm told is ably represented by Mrs. Adetoro. Mrs. Adetoro, please can you come up to give us your presentation? Thank you very much. Can we have our slides?
Good morning, everyone. I bring you greetings from the Permanent Secretary, LASHMA, Dr. Emanuela Zamba, who is also a member of the Aphpn and very passionate about public health. She would have really loved to be here today, but she's unavoidably absent. I hope I'll be able to do some justice to the presentation like she would have. So are we having the presentation coming up? We will be speaking from the health financing aspects. The Lagos State Health Management Agency, like you all know, is the agency responsible for providing affordable and quality health care for all Lagos residents. And as such, we'll be speaking from that point of view. I'm trying to wait for the slides to come up. Do I have my version here? My outline this morning is very simple. I'll be giving an introduction. I'll be talking about the case for rethinking investments, what a paradigm shift looks like, and then I'll delve into the Lagos model. As Lagos State Health Management Agency, as a state government, what have we been doing in the area of health financing, and then wrap it up with that. Are we good? Okay, I'll use that time to do some marketing. How many of us have Ilera Eco in the house? Do you have our Ilera Eco plans? Thank you very much. How many of us do not have health insurance and are interested in? Okay, okay. I'll still market Ilera Eco after. Okay, so you want to give me a clicker or you want to? I've been told I have 12 minutes, so I'll try and do justice to the topic. Okay, I'd already told us about the outline, so I'll go straight into the conversation. For those of us in low and medium income countries, we're actually facing a lot of pressure around health. There's the issue of HR for health. There's the issue of population growth. We have very explosive population like a state like Lagos. We have increasing disease burdens. We are moving from communicable to non-communicable and things like that. And then even just recently, donor funding has been cut short a lot. So it means that we have to start rethinking how to finance our health. These pressures really have demanded we really reevaluate how do we want to make sure that we have equitable and sustainable health sector. And the goal for everyone is actually achieving universal health care, universal health coverage. And this requires moving away from fragmented to pooled investments, which must be sustainable, because if you start it off and we are not able to continue, the harm is even worse. And it must be equitable along the rise. So that leads to our topic for today. what can we do? We need to strengthen governance. We need to be more efficient about how we allocate our resources. And we need to invest more in those primary care services, the digital health, and most especially social health insurance. So what does that mean to us? Out-of-pocket expenditure is still really high on this side of the divide. A lot of people, when they go to the hospital, they still really have to pay a lot. And WHO says that in Africa, it's about 44%. This is pretty high because the recommended threshold is 20%. So it means that a lot of people are having catastrophic expenditure around their health. And then only about 23% of adults have any form of financial protection around their health status across 28 countries. In West Africa, where Nigeria belongs, this is even pretty very, very low, with just about 10 to 15% of residents having one form of health protection or not, or the other. So that you're able to get, the more you make the poll, the numbers on inside the poll, the more resources you get, the more things you're able to cover, and everybody is happy. And finally, it's also like a social security system whereby everybody there's a government-backed framework for it. So what does a paradigm shift look like? For us, we'll say it's moving from fragmented to pooled and sustainable financing. It's also moving away from, oh, it's voluntary. It has to be mandatory. Everybody has to everybody has to be a part of health insurance. And then we also added that it's moving away from paper-based to digital first. That makes it more efficient and effective. So what is the Lagos model? I'll be looking at how we operate this in the Lagos state. I'll take us to the LSHS law. The LSHS law, as far back as 2015, Lagos state said everybody should have health insurance. And the idea was to make sure that the Lagos residents have access to quality and affordable health care. And this was put into law by the Lagos State Assembly. And that law set up three things. It set up the LSHS, which is the Lagos State Health Scheme, which I said it is mandatory to have health insurance as a resident of Lagos. It also set up LASHEV, that's the Lagos State Health Fund. That's an independent fund that is ring-fenced by law, where the monies for the health insurance, the premiums, the contributions go into. And when I say ring-fenced by law, it means that the way the monies come out of that fund is backed by law. And then it set up a third thing, which is the agency to implement this law. That is the Lagos State Health Management Agency. And we are supposed to, the agency is supposed to regulate, supervise, and ensure the effective administration and viability of the LSHS, which is our agency, LASHMA. And the objectives of the LSHS are very simple: protect families from financial hardship, ensure everybody has access to quality and affordable health care, reduce out-of-pocket, ensure equitable distribution. It's not skewed to any direction, and then maintain a high standard of healthcare delivery. Whenever we keep saying affordable and quality, a lot of people say, is quality affordable? But the idea is that you can make quality affordable by regulating, supervising, and increasing the pool. So what have we been doing? What are some things, if I'm to speak about all the things we do at the agency, it will be a lot, but what are some things? The first thing is mandatory health insurance. That's something that will help to make sure that it is sustainable. We have the LSHS law 2015. In 2022, former President Muhammadu Buhari, he gave the NHIE Act that now said it is mandatory for every Nigerian resident to have a health insurance. He went further to even say that you must have your state's social health insurance. So what did we do in Lagos? In Lagos State, we domesticated this NHIE Act, which gave birth to what we call the executive order that was signed into law by our governor, Mr. Babajide Sanwo-Olu, in July 2024, that said every Lagos State resident must have health insurance. And then we also are aware of risk pooling. How can we grow the figures? How can we make sure that the informal sector, the SMEs, not just corporates, are buying insurance? So we do a lot of public awareness. We widen our presence. We make sure that we have offices in all divisions. We have kiosks in all local governments. We're on radio, commercial radio, and even our own home radio. We have the Ilera Eco Spotlight. We can listen to that online. It's an online radio, ileraecospotlight.com. Creating awareness. We're on the roads. We're at programs creating awareness. We also made sure that after creating this awareness, and people are willing and ready to register, how do they register? So there is ease of registration with your phone from your privacy of your house. If it is, if you have a smartphone, you can go online. If you have a feature phone, you can use USSD to register. You can speak to our agents. You can walk into our locations. And there are so many payment channels. We do not collect cash. Cash is not collected. So we have various payment channels, banks, online that people can pay just to make sure that people have access to Ilera Eco. Apart from registration channels, we're also expanding our provider networks. When you come and you buy the Ilera Eco, what next? You need a hospital where you can access this care. So we are constantly expanding our provider network to make sure that people are able to choose a provider around them. And finally, the benefits package. What's in it? What is covered? When you pay this premium, what are the things you have access to? So with our in-house actuarial capacity, we are constantly, I've used 12 minutes. Okay, please give me 2 more minutes. So we also, in terms of equity, what we have done is we have an arm of the agency called EcoSha, which is the Eco-Social Alliance. This agency is responsible for, in addition to the equity fund, which the government already gives us, the equity fund is a first line charge. What that means is that every month, the agency gets something for the vulnerable, and we are able to gather more, we are able to source for more funds through innovative ways to make sure that the vulnerable in the state are covered. We've also adopted technology end-to-end to make our processes more effective and efficient. These are some of all the areas where we have adopted technology. The law has also adequately addressed governance. Governance is very key. It has addressed accessibility, financial protection, private sector participation, equitable distribution of healthcare costs, quality, efficiency, demand, and resource pooling. Our purchasing mechanisms are very transparent. Our feedback mechanisms are across multi-channels and 24/7. The community is involved. We are in collaboration with CSO, and we have a regulatory framework. There's an arm dedicated solely to regulations, and there's also a consequence management to make sure that things are done well. I had already spoken about the executive order. The executive order also adequately addresses mandatory health insurance, vulnerable coverage, public awareness, and emergency care. Okay, so in conclusion, sustainable and equitable health sector investment is no longer optional. It is something that It's no longer optional. It is essential for all subnationals and national health systems to thrive. We need to strengthen our primary care, enhance accountability, and support long-term resilience. We also need to have a commitment, state commitment. Everybody needs to be committed. There needs to be strong partnerships for this. And in Lagos, enforcement of the Lagos State Health Scheme Law, NHIA Act, and executive order ensures full participation and system sustainability. Thank you very much.
Thank you so much, Mrs. Adetoro, the Head Planning, Research, Monitoring, and Evaluation for LASHMA, for your presentation on behalf of Dr. Zamba, the Permanent Secretary of LASHMA. Thank you so much for showing us what Lagos State is doing.
There's the platform where they can access care, and we've partnered with pharmacies all over Nigeria. And basic primary care is what we deliver on that platform. Where, I mean, from our data too, we see that malaria and many other common primary care diseases are #1 diagnosis. So they're able to go to the pharmacy, they have a connection to telemedicine, and they're able to access care. But what do we see? All these bricks and mortars have not brought solution. Number 2 is that providers are underfunded at the point of care. I mean, we all know that. I'm glad the people from private practice are coming also to tell us their experience. Patients also pay out of pocket. This is data, this is fact. 70% are still paying out of pocket because they don't know about health insurance. Those that know about it cannot afford it. Those that even want to afford it, there's poor regulation, and even the health insurance are not really well regulated, so that many of our partners are actually, or co-HMOs are owing hospitals. And, you know, I'm glad that it's even hospitals that are marketing AXA now. When people come and say, look, don't go there, go to AXA Mansard. And I'm not joking, that is actually what is happening. It's the hospitals that are marketing us now because we make it our point of duty not to owe any provider. And I know I've been in that place, working as a consultant family physician. And when I needed to go back, because I started my career in the HMO, then went for residency and came back. And when I needed to go back, I did my research before I went for AXA. But even beyond that, I also made up my mind that I wasn't going to go back to that nonsense of going to beg hospital. Sorry, we'll pay in the next 6 months. I said, no. I must be able to stand for the colleagues and make sure that hospitals are well funded. And I wanted a system that would support that. And I found out in AXA. Now, digital tools exist, but systems don't talk to each other. This is a big problem. And we see that from the state to the federal, silos of all sorts of apps and people doing their thing. Of course, don't even talk about hospitals with their different EMRs, electronic medical records, that are not connecting. So what do we see? A patient wants to move from one hospital to another one, and they say, no, we can't take their record. You must do all the tests again. Even when they print all the results, CT scan will remain CT scan. MRI is the same. Somebody has a cerebral infarct, a CVA, cerebrovascular accident. She's been managed, and we want a physiotherapy or something else in your area, but neurologist wants to follow up, and somebody said, no, I want the same bouquet of investigation before I can take over your care. Meanwhile, abroad and in developed countries, people have cross channels of interaction where they can share information. And if somebody has had an infarct and she's been rehabilitated, you're just following up and helping with the physio and checking that there is no second stroke and everything is going well. So a lot of digital tools, even in the States, but systems don't talk to each other. Now, investments also don't solve fragmentation. That's a big thing all of us need to know. You are investing in all the silos, in all the local government areas. They are not going to solve the problem. Rather, they can actually deepen it. Now, AXA Mansard sees these gaps daily across our provider network, in the claims pattern, in our fraud analysis, and in the patient feedback. And that's why we've come up with this solution of the way forward. Now, this is our new investment. A new investment philosophy for Nigeria's health sector that we propose and that we're actually working on. That to build an equitable and sustainable health system, Nigeria must rethink what it's investing and why. The shift is from structures to systems and from transactions to outcomes. This is important. And what should we be investing in? Number one is connected system, not isolated structures. I've talked about working in silos. All the systems must be connected. We must have some connection. And I'm happy to tell you that the NHIA, the regulator, led by Dr. Kelechi Ohere, is actually building a digital platform that AXA is supporting. Our CIO, Chief Information Officer, is actually championing that, where we're helping them to build a big digital platform where all the HMOs can be connected and we can have data sharing and have some form of regulation and integration instead of working in silos. So connected system, not isolated structures, primary care as the foundation. We must thank God for our fathers that have laid the foundation. I remember Professor Liko Ransom Kuti and many others that have gone and done well. Laying that foundation of public health and primary health care in Nigeria. So primary care is the foundation. People must be able to access basic primary care. And people should stop dying from preventable infectious diseases like malaria that we're still having in our country. So primary care is the foundation to strengthen the first point of care where inequality starts and can be prevented. I don't know if it doesn't pain your heart that you still see children. Let me not mention Massey Street Children's Hospital. And when I was doing my housemanship, oh God, I just used to cry there. That was one reason I could not even go into pediatrics, because all those children with kwashiorkor and malaria that their mothers were giving agbo and all sorts. And then they bring them, and I'm like, how do you people cope looking at these children and you're trying to take care of them? Because I'm just too emotional. And the first thing I asked the mother, why did you wait till this child became like this? And we're saying that they can have access because we should provide that access in primary care, primary health care. Now, digital infrastructure as health rails and not as silos apps. A lot of apps, a lot of digital tech. There was a seminar somewhere in Dubai talking about healthcare. We had another one in Kigali. Africa is full of health techs. Talk about it, we're there. But can we be integrated? And then the workforce stability, this is so critical. Our guys are going every day. Going every day to the US and UK. And I remember recently three of our doctors, we have a hospital by AXA called One Health Medical Center, Ikeja, and we just opened another one in Victoria Island and Murio Kola. And three of our doctors were going to the US. They've done their USMLE. They actually had residency postings in 3 different states, and Trump banned them. So whether I'm happy about that or not, of course, I'm still praying for them that other opportunities will come. But every day, the doctors are moving. The nurses, the physiotherapists, all the healthcare workers are all planning to leave. So how can we retain them? The Commissioner of Health, Your Excellencies, and all the ministers, we need to think about this. Why are we going abroad? Where are they going? Because of better environment and better remuneration. But we can do better. We can try to retain, because we must think long term. In the next 5 years, in the next 10 years, how many will be left? Right now, we're doing 1 doctor to over 10,000 patients. Talk about burnout. We've heard of doctors collapsing post-surgery. Everywhere, in all the states, we have a platform of doctors all over the place. It's not okay that our doctors are going through burnouts, and the nurses too, everyone. We must retain our workforce. And lastly is on data-driven oversight. Using real-time insights, not reactive firefighting approach to guide resource allocation and governance. This is important. We have data also in silos. Everybody's keeping their own. AXA has been for over 12 years now, and we have our data showing all the patterns and trends. Many other HMOs are also there. But let's even talk about hospitals. Everybody having their data, or the local government. They collect all this information, immunization trends, disease pattern. But can we begin to share it and use it for resource allocation? We always know that there's this meningitis belt and outbreaks every year. How many of those in those northern states have been vaccinated? CSM vaccine, type A, type C. The people are not getting it, and people will still die when the epidemic starts again. So we must use data to plan and put resources in the right places. All right. Our position on technology and integration. All right. Our position on technology and integration. Before then, we have our practical contribution to an equitable and sustainable system. What has AXA done in bridging this gap in making it an equitable and sustainable health system for our population? Number one is a digital-first health infrastructure, health insurance infrastructure. We've built a system that automates enrollment, claims, utilization, and provider payments. We call it our core business application. It's an IT application. We call it Euphoria. And this time it was built in Nigeria. The one we're using, formerly called Toshfa, was from India. And then we migrated and got our local programmers, and we did Euphoria, which is able to integrate everything. We have a provider platform. We have the enrollee also logging in. We have everything integrated, from payments to disease pattern and data reviews, analytics going on. Now, this also shows us, the analytics shows us leakage, where leakages occur, and guiding smarter investment for the sector. We have in AXA what we call an FWA team, fraud, waste, and abuse. And of course, we report to our region in France on all these things, because we know providers also do fraud. Somebody has an encounter for malaria 7 times in a month, and they are billing us for 7 times. Of course, that cannot be. And then we go and make it up with them. So we audit the claims that are being paid, and we also even call our enrollees. We call that care check. But basically, that's because we have an integrated platform that can show the pattern, and they will show that, oh, Jade Sola, they visited One Health Medical Center 7 times. Or sometimes we see a family going to the eye center, and everybody has glaucoma. Yes, we know it runs in families, but even a 3-year-old is having eye drops and all the things, and we're wondering what's happening. We call the enrollees, and we want to find out what is happening. So a digital first health infrastructure is what helps us to integrate all these platforms. The other thing is provider relationship strengthening. We have a robust system. This year we've done 4 provider fora across Nigeria, Southwest, everywhere in the geopolitical zones, where we call our providers together. We want to feel their pain. When the new government came in, and then subsidy is gone and everything, and then cost of fuel, running the hospital, all our providers increased their tariff. Even though in the contract, in the SLA we signed with them, we don't do it, but in every 2 years. But we had to listen to them. How many minutes? All right. We have to listen to them to know what their pain points are. So we have a very, very robust system of relating with our partners. Now we operate as a payer, and through partner hospitals, we understand the realities on both sides. Our work has shown that timely, predictable reimbursement dramatically improve provider behavior and patient experience. Like I say, it's the hospitals that are actually marketing AXA Mansard now, because they know AXA is not owing them. And they are the ones, when clients come, say, which HMO is working? Which one is AXA Mansard? Now, that is because we want them to give our patients the best of care. We want good outcomes. Workforce-centered investment model is also important, like we've said. And our experience in the hospital operations is that has shown that if you invest in talent, the outcomes multiply. These hospitals are having high turnover of staff. So what do? We have a training for HMO officers. We even have a training for our MDs, teaching them on business. Some businesses, the MD is the same as the accountants, and they don't even know anything about all this management thing. So we teach them, we get all the finance experts, do training for HMO officers, do training for our doctors, nurses. So across board, we're investing in talent. Of course, the truth is that if you ignore workforce sustainability, no amount of infrastructure can save a system. They will leave Nigeria. They will continue to leave until we find ways to attract and retain them. Now, we believe in co-investing in clinical training, digital literacy, and quality improvement. The last one is on population health and data. We know data is the new oil, and it's so important. All our data across board, we must get them together and look at the trends, medication gaps, utilization pattern, and how we can make it better. And lastly, it's going to be our position. Our position in a new investment philosophy for Nigeria's health system. What do we... Okay. Our vision for a sustainable healthcare investment and our position on technology and integration. We expect that the private sector should build system with NHIA interoperability from the start. This is actually what we're doing, where we have NHIA supporting them to build a technology platform and having integration of all the HMOs and all the other providers, the hospitals, all coming on board. And the goal is that the private sector building with NHI will have an enrollment data exchange, so that even if somebody is porting from another HMO, their data, bio data and everything is there, and we don't have to start afresh. Utilization and consumption data, this is also important to us. What do we see at the end? This is end of year, we're doing our renewals. So one HMO or one company says, look, we want another one because somebody is giving us at a cheaper rate. But we are now exchanging ideas. Say, look, that company, and I will not mention it, they will owe you. They don't even pay. Better be careful. They have owed us for 3 years. That's why we are even the one that told them we will not continue to carry this burden. All right. And claims transparency. And lastly, our vision for a sustainable healthcare investment: prioritize primary care strengthening, gatekeeping, early detection, chronic care continuity. I must mention that we have a chronic care desk where all the patients on chronic care have access to pharmacies where they can collect all their medications without having to go to the hospitals all the time. Preventive health engagement, digital trial to reduce costs, medicine supply. Now, this investment reduces costs for payers and disease burden for the population. Technology as an enabler is also important. And the most sustainable investment, this is where I'll end, in digitization that permanently reduces operational waste is that automation reduces claim cycle. We are able to process our claims in 7 days, and we're paying providers not even in 30 days anymore. Eliminates fraud and improves provider cash flow at a systems level. Universal health coverage will not happen through infrastructure alone. They will come through collaboration, interoperable system, integrated financing, and data-driven governance. The private sector must be seen as a partner in the national health objectives and not just as a vendor. And investments should follow disease burden and impact potential and not political geography. Our commitment to a more equitable health system is working with provider management, performance management, health analytics, data analytics, digital integration, sustainable finance modeling. And lastly, a call to action is that Nigeria can achieve a true health equity only if we invest in foundation and not in facade. Thank you for your time.
Thank you so much, Dr. Edo, for your detailed and insightful presentation. I'm not focused on the problems. What should we be investing in? Connected systems, not isolated structures. And thank God we are here from different sectors, with primary care as the foundation, according to what she has told us, and digital infrastructure, workforce stability and capability, and data-driven oversight. Thank you so much. We go right ahead to the third presenter, who's our third presenter is the CEO of Farm Access, Dr. Njide Ndili, the president of Aphpn, and she's ably represented by Mr. Sunday Ngbejume. Is he here? Okay. Mr. Sunday Ngbejume, representing Dr. Njide Ndili. Please, the presentation, please.
Thank you. Good morning, distinguished ladies and gentlemen. I am standing on existing protocol, ably representing Mrs. Njide Ndili, the country director, Farm Access Nigeria, who also doubles as the president, Healthcare Federation of Nigeria. So before going straight into the business of the day, like I've seen the other speakers do, let me also just quickly, within a minute, tell us about what Farm Access does. So Farm Access is a development organization with a very strong focus on the health sector in Nigeria and across Africa. We do quite a lot, mostly in terms of health system strengthening, We do quite a lot also in terms of healthcare financing. We support government in policy formulation and evaluation. We also try to see how we could blend public capital with that of the private to see how equitable access to care can be guaranteed, to the Nigerian people. We also do quite a lot in terms of capacity building. Quite a lot that we do. But we have a very strong inclination for quality through our safe care programs, quite a lot. But I'm going to stop there for that. So let me just go straight to the concept, the topic before us. And we've been talking about how we could rejig investment thinking. So let's start off with what the current situation is. Now, what we currently have, which I refer to as the traditional approach, is just like what the last speaker said. The current mode of investment is focused largely on the brick and mortar, which I refer to as infrastructure here. And then, of course, some episodic donor financing, from time to time. Now, the current traditional investment model is focused on spending volume. If you notice, most times, you'll see they will mention, oh, this is the budget for healthcare for the state, budget for healthcare at the national level. But it goes deeper than that, okay? The current investment model doesn't emphasize value. It doesn't emphasize efficiency. It doesn't emphasize effectiveness. It doesn't emphasize the service reach and its quality. Okay? And that puts, a lot of pressure on the recipient in terms of the people who access care. Okay? Those are some of the things that characterize the current existing investment model. And then, of course, lastly, we are looking at a situation whereby the population impact, approach to investment should be what should be guiding investment in Nigeria. There are so much details, but of course, some of these, the two speakers earlier on had touched on some of them. But these are just the summary of the current feature of existing traditional investment model that we currently have in Nigeria. So now there are impacts for them. We've seen the features, but what are the impacts? One of them is that because the level of investment coming in is not adequate, is fragmented, and is laden with a lot of inefficiencies, you realize that people now have to take, kind of like carry the burden of funding healthcare access by themselves. 75%. What you have on your screen is about, I think, 8-year distribution of financing numbers from 2010 to 2017. You discover that on average for those period of years, the largest financing entity for healthcare is the household. Household, 75%. By the time you combine investment coming from the federal, the state, and the local government, it's a far cry from that 75. And the corporate is also there. So it's a huge burden that has been transferred to the population. Now, what's the second impact? As a result of the first impact we saw, you realize that healthcare financing has become catastrophic. Now, we use that a lot. What does catastrophic really mean in financing terms? It simply means that for the total budget of the household, the moment what it costs you to access care hits 10% and above, it becomes catastrophic. It becomes catastrophic. As at 2019, we were still doing something around 6% or thereabouts. But as we speak, it's way beyond that. Now, this is a distribution of healthcare expenditure for household as at the middle of last year, Q2 2024. Can you compare what we have as at middle of last year, 2024, to when we even had COVID? Can you see that? So, household expenditure capacity is declining significantly. As at Q2, 61%. That's the total for the household. Now imagine what now happens to health as a component of the expenditure budget. So if there's any word or terminology worse than catastrophic, I think it will better describe the situation or the reality. Now, just to drive, we're talking about the impact of the current pattern of investment financing in healthcare. This is the impact. To the right of your screen, you will see that as at October this year, the World Bank announced that the poverty level in Nigeria has surged. Between 52 to 56% of our total population. That's massive. And what is the metrics for that? $2.15 a day. $2.15. If you do $8, the number is close to 190. It's as bad as that. And it's terrifying. And then, of course, the contribution of healthcare as a percentage of GDP is still under 5%. So that tells you that indeed, I personally agree with those that framed the topic of today, that there is indeed a need for an urgent paradigm shift. First, starting with the way we even think about it, rethinking. I completely agree with that very topic. So, what paradigm shift should we begin to, drive at as a country? Let us start off with, what the new investment model should be like. The traditional one entails mainly about, we built 1,000 hospitals, we built 200 or whatever, and then we have X beds, we have this, we have that. Fine. That's the old method. But look at the impact. Okay? Now, we want an investment model that takes into consideration, all right, quality. 5 minutes. Whoa. Okay, thank you. Quality, sustainability, and equitability of access. So any investment model or financing model that we are running that doesn't have these three elements embedded will not give us the kind of result we want to see going forward. Honestly, there's so much into it, but because of time, I can't go further. Now, the new model must be inspired by the universal healthcare system that has been kind of like canvassed by the World Health Organization. This is the UHC Cube. I think one of the speakers mentioned this earlier on. Okay? Now, what does it say? I hope. Okay, we can see this. All right. So what it entails, you can see that there are 3 dimensions there. There are 3 dimensions. One is for the population that you're covering. You see that the box in blue represents the resources available. And it's pressed in 3 dimensions. It doesn't cover the bigger box completely. So those spaces there are the gaps that we need to fill. everybody needs to be covered. So whoever we are able to cover now, we need to do more to be able to bridge the gap in terms of the population coverage. Then secondly, the service reach. Okay? Maybe out of 10, we are only able to do 3. We should be able to now extend it to cover the remaining 7. And then, of course, the financing side, which we have the household having to pay for out of pocket. And what it does is that when they do that, many of them slide down below the poverty threshold. And we'll get to find out in a minute why that is also not good for investment. We're going to find out why that is not good. So what do we need to consider going forward? You see, we cannot treat healthcare in isolation from the larger economy. We cannot. A speaker mentioned earlier, when we started speaking, that healthcare is not cheap. It's not cheap, right? Now, the issue of affordability now comes in. So when you say not cheap, it means, is it really affordable? It comes in. So whatever policy that is churned out at the macro level, it impacts on the ability of people to pay for it, whether in terms of premium or whatever the case may be. That's one. Then 2 is that on the healthcare supply side, the health businesses also need to be encouraged. You are buying equipment, you are investing in medication, you are paying taxes. You know, there's a tax review now. We don't know whether the health care supply side of the equation will be, to what extent are they going to be immune? Okay? We don't even know the details until they start implementing. So we need to also encourage and ensure that the indices that ensures that health businesses flourish are also, critically looked at. And one of them is access to credit. Access to credit. Okay? If you look at the CBN's data, you see that of the total credit flow in the Nigerian economy, healthcare businesses only had access to 0.29%. Not even half a percentage. 0.29%. It's difficult for health businesses to access care. So if you want to spread and want to build a chain of PHCs around the country, where is the money to do that? Who is going to pay for it? When we have less than 10%, with all the insurance, everything, less than 10% since inception. Meanwhile, Rwanda is doing 92 to 93%. So those are the issues that from an investor perspective, I'm just wearing the cap of an investor now, that they'll be pushing back to us that look at these issues. We also need to take cognizance of them. The other point is equity-led financing and risk equalization in terms of equitable access, risk equalization. What people who are well-to-do are able to get in terms of quality should also be available for those who are earning low. Apple for apple, orange for orange. So it must be equitable. So how do we take care and equalize the risk? All right? That's another area that needs to be considered. The other one is sustainability first capital model. Because every now and then there is no money, there's no money, there's no money. All right? But we are floating bonds every now and then. Oh, savings bond. Oh, climate change, green bond. And people are buying. People are paying. Money is coming in. We can replicate a similar strategy for healthcare. It can be done. It can be packaged in a way that you'll be able to attract private capital into healthcare. And one of the examples I gave is that of the impact bond. Impact bond. How many of us are familiar with impact bond here? Impact bond. Okay, let me just, a minute please. Just explain what it means so that, I don't know which investors are here or policymakers, but I think we need to hear this. Now, what it does is this. Now, we are having issues around investment flow into healthcare, whether in terms of infrastructure or ensuring that the poorest of households are able to access care. So we want to improve number of people that can access care, on that lower income cadre. So what can we do? Government can say, you know what, let us come up with a bond. All right? We want the numbers of the poor accessing care to grow by 50% over the next 5 years. Okay? That's the outcome we want to see. Then we need this amount of investment to come in. However, at the end of that period, once we are able to confirm the performance of this outcome, you will get a certain return on that investment. Let's say 10% or 15% or thereabout. Okay? But how can we do that? So now, if that is guaranteed, the private guys can bring in the money, and then the outcomes is achieved. And then what happens? Governments and other outcome funders, like this Dangote Foundation and the rest of them, MTN Foundation, they can partner with government and say, okay, we've been able to achieve this milestone. We are paying you back your principal and the return on it. Once we can demonstrate that trust, these guys will keep coming with their investment because they know that 15% return on it will surely flow back to them. So it's just an example. The other one is what we call the sin taxes. How many of us are aware of this sugar something beverage tax? Very good. Tobacco tax as well, right? Now, the reason why these taxes were levied, okay, was because of health-related issues. Am I right? Good. Now, if because of health concerns, these taxes were levied, and these people are actually paying these taxes and reporting them in their annual financial reports. Are we together now? Okay? That's a sustainable way. But the only thing missing now is rerouting those funds to the sector that raised the concern in the first place. So what is currently being done is that they made those money and spread them across board. Meanwhile, the sector that triggered those sin taxes is not getting anything from it. There is no way we can make progress. Some level of accountability should be established in this order. We need to ask some questions here. Because now we are doing, is it 10 naira now per liter of sugar, or is it per kg of sugar or whatever? They want to make it 20 now or so. Where is the money going? It should be rerouted back to the system or the sector that triggered it in the first instance. There must be transparency on it. And that's a very, very sustainable way of bringing in investment. So once those kind of sin taxes can come in, then private capital can come in with a guarantee that such financing inflow can pay back the investment for them. It's possible. Now, the other point I'll just quickly rush through because of time is health system strengthening. I think the other speakers have dealt with that extensively, and data as well. But in all, I would like to add this to it and then round up. You see, the fragmentation of the health system in Nigeria is obvious. It's clear even to the blind. Silo playing and everything. We need to start looking at the health sector with a systems thinking mindset. A systems thinking mindset. What we currently have is winners take all. It has to change. Then the concept of interoperability of systems is also very important. Okay? You can't be in Abuja and then you have to come to Lagos to see your doctor if you are down. You should be able to walk into any other place, anywhere you find yourself, and still access care. It was even part of the NHIS, the former NHIS before they became NHIA, part of their of their strategic plan, interoperability, but it was not done for decades. So we need the political will. We are not lacking in ideas, we're not lacking in policies. It is the political will to move the system, and we'll get it, right. On that note, I'll say thank you very much for that.
Thank you so much, Mr. Sunday Mbejume, for that detailed and robust presentation. Takeaways for me: systems thinking and integration. There's too much fragmentation. So we should learn systems thinking, not working in silos. And for the rapporteurs, since we're going to be producing a communique, all those syntaxes that's derived from trying to prevent chronic non-communicable diseases should be directed solely at the health sector and not spread across several sectors. Those are some key takeaway points for me, and I think that should be reflected in our communique. We'll go right ahead into the panel session, and to moderate this session, I'd like to invite Dr. Bolaji Obade, who is the Chief Medical Officer, Deloitte and Touche.
Payment that the corporates pay when they subscribe to the corporate plan through data. So anybody subscribe to Airtel or Globe or even MTN, when they buy their data, they're able to access the Airtel AXA insurance. And then once they subscribe, there's a USSD code that through a telemedicine platform and a pharmacy platform in their local government area, once they subscribe and press that code, so a data is taken, which is monthly. So basically, once that is deducted from them, they are able to access healthcare through a telemedicine platform, which makes it affordable. They are not paying the lump sum 12-month payment or premium. They are paying monthly once they need to access it, and that makes it affordable. And of course, because it's malaria, upper respiratory tract, we are able to help them. And of course, we also insist on standards. So recently, we've been able to even set up what we call a campaign plan, where we are training pharmacists in following guidelines and SOPs. I mean, no malaria should be treated until you do a malaria parasite test. And we have the rapid test kits, WHO accredited, that we insist they do. So even in our pharmacy-led practices where they can go to, we insist an MP should be done, because not every fever is malaria. We know people just walk into those pharmacies and they say, I have malaria. We're changing the behavior to tell them, stop giving them those bouquet of antibiotics and anti-malaria. Please, can you give them the right thing? Do a rapid test, confirm it's malaria. When it's not malaria and it's a viremia or anything, can you refer? We also have a robust referral platform where hospitals within the network of that local government, I mean, we partner with all the hospitals in Nigeria, over 2,000 hospitals. You can now refer once it's more than malaria. And that is helping to change behavior. It's helping to change practices. Microinsurance is here to stay. For those that cannot even afford it, we have other forms of insurance where we partner with microinsurance banks. So sometimes we have this microinsurance product like our AXA Pass, where they pay 1,000 monthly also through the AXA card, and they're able to access care. And for those that insist on the corporate plan, even on our lowest plan of the bronze, we have bronze, silver, gold, platinum, platinum plus, and then rhodium and the international plan. We have some form of prepayment and microfinancing. So once you register with any of these microfinance banks, you don't have to pay the whole premium if it's a monthly payment. But what we just need as a collateral is that you have a bank and you are making some savings, and gradually we're deducting. So making it more equitable, making it more affordable, even for the rural poor. Thank you.
That's really interesting. And I think Ogun State has a similar plan, but they are restricting their own to maternal care.
Yes.
Ensuring that when a woman is in labor, she can use this type of arrangement to access transport without paying. That takes her to the nearest facility to access care without paying and get her baby delivered. So there's a lot of innovation going on in the health sector. I think one of the problems we have is that we don't document many of the things that we do. People are not publishing the success of some of these little small initiatives. I'll move on to, thank you very much, Dr. Idowu. I'll move on to the Association of Private Medical Practitioners of Nigeria, Dr. Esegine Jonathan. Thank you very much, sir, for coming. There was a very interesting discourse on LinkedIn this last month, November. This is now December. Talking about mergers and acquisition in healthcare is something I'm passionate about as a health economist. And by the way, most of what we're talking about today is about health economics. Let's just call it what it is. And we should have more health economists within our health system, thinking about how we finance and the economic implications of our decisions. So, sir, that discussion was about how we need to move from small cottage hospitals owned by the private sector to bigger hospital chains where a hospital management company can talk about having 1,000 beds, 2,000 beds. The advantage of that being that the standards and the quality is driven from the center. So whether you own 10 hospitals in your chain or 20, the same standards will apply across board. There'll be efficiency in how they are purchasing, efficiency in the logistics. I'm just wondering, what's the take of your association on what we've seen working in the financial sector? Is that something that can work in healthcare in terms of a new way of investing, not in 7 beds or 15 beds, but in 1,000 beds?
Yeah, thank you very much for that question. I am here representing my national president, K.I. Deshola. Like you have heard, my name is Dr. Isegina Jonathan. I'm the Lagos State Chairman. What you have just asked has been a recurring topic amongst us private practitioners for many years. And just like we gather, like in this forum, we talk about our problems, either in the health sector or in the general society. We also gather, there's no forum where doctors are gathered that we don't talk about how do we improve our service delivery? How can we be more efficient? How can we be more contributory to the well-being of society? And it has been identified that solo practices, small practices are not viable. They are risk-prone. Once anything happens to the proprietor, the business dies. We all know these things, and we have accepted them in principle. But how should this discussion translate to reality? That is where we are stuck for many years. Personally, I observed that the more we discuss, the more resolutions we make, the more people dig into their own private thing. And so many things, so many reasons have been profiled: lack of trust amongst ourselves, suspicion, and then beyond us, difficulty in accessing finance, like pharmacist has identified when he was making presentation. It is difficult for small practitioners to access funds. In fact, the money market does not have provision. Once they hear is hospital, they switch off. That is the way it has been, and it is still very much so. In fact, it's worse now that the cost of funds has risen astronomically. They don't want to take that risk. And so what is the way forward? If we are able to come together and access funds, then the issue of merger and setting up proper business that is centrally managed, you just come, do your clinical stuff, and somebody is administering the hospital and allocating resources where they should go, will solve a lot of problems.
Indeed.
I hope that the society or the government will pay attention to this thing. There is the need to finance the private healthcare sector.
Yes.
Talking about official political, what is it called? Like a few years ago, they were saying that Nigeria is the biggest economy in Africa.
Yes.
Based on GDP. GDP does not translate to wealth of the society. What reflects the wealth of the society is the health of the people.
Yes.
We have been talking, we are the biggest in Africa, mortality, maternal mortality rate has not improved.
Yes.
Infant mortality has not improved.
Yes.
Neonatal mortality has not improved. So long as those indices are abysmal, then as big as political leaders want to think grandiose delusion, we are poor.
Okay, sir.
And it is that poverty that is generating all the problems that we have. How do we solve that? The society must invest in the health of the people, must pay attention to social determinants of health of the people.
Yes, sir.
Must make sure that there is food security.
Yes.
There must be education for the people, and there must be. Right now, I want to include something there because of what is prevailing. There must be security.
Okay, sir.
So, my organization, we have, as fragmented as we are all over the whole place, the rural area, riverine area, and all of that, attending to the health of the people. We also attending to emergencies. We have challenges, emergencies. The new Health Act says you must not refuse the emergency on account of money. You must treat, and then when you have treated, you must not detain anybody because he's not able to pay.
Yeah.
But nobody is guaranteeing how practitioners will be refunded. These are all the problems we face.
Is financial literacy. How can they come up with business cases that resonates with the bank? If you don't speak the banker's language, they can't handshake you.
Yeah.
So, but because of time, I'm just being. Another thing is they need guarantees for that risk.
Okay.
In one of my slides, I didn't really mention, but it's on the slide. There's an entity the government floated this year. They call it the National Credit Guarantee Company for healthcare. It just took off, but if some form of underwriting can be done by such an entity or a DFI like BOI, for example, if BOI, for example, has, let's say, 200 billion to support healthcare businesses, of course, they would offload those funds to the normal commercial banks. Now, when those healthcare businesses go to those commercial banks to access funds, the DFI funds in their custody helps to underwrite or de-risk that investment that the bank want to make in you. So if you need 10 million, for example, the DFI funds in the custody of the bank can underwrite that 10 million to the tune of 7.5 million. So the bank knows that if push comes to shove and you want to, they're not doing well, 7.5 million is already in their custody. You should be able to make up the remaining 2.5. And then let you and the DFI deal with the issue. So they are safe, and then funds can flow from them to the businesses that need them, irrespective of your size.
Okay, thank you, Mr. Ngbedune. I'm going to go to Dr. Idowu still on this matter of M&As, because I think, I think that if we're talking about rethinking how we finance the healthcare sector, and we are not including the private health facilities in the discussion, we're still not going to go very far. Dr. Ngbedune, Mr. Ngbedune has said something very important, that the banks did their own M&As because they needed to protect the capital of depositors. We will be doing the same thing in the health sector because we want to protect the health of those who use private facilities. So my question is this. Again, is it time, as a manner of rethinking how we fund our private health facilities, is it time to begin to look at them as clusters so that there is some strength in terms of financing, strength in terms of operationalization, strength in terms of logistics, and all the other things that have to do with managing a health sector? I think Lagos State has actually done that with the districts that they've done with the primary healthcare system, because they are functioning now in clusters. And I can see efficiency there straight away.
Yes, thank you, ma'am. You are right. Mergers and acquisitions will help efficiency and interoperability. So basically, it's going to work better as a public-private partnership with government support. So when we have tax holidays, for instance, even when people come together, and we have over 2,000 providers across Nigeria, talk about all the hospitals across all the geopolitical zones, they are in our network. Now, the biggest and those that have had better efficiencies and of course cost more are those that have had this venture capital funding that have over 100, 200, 300 beds. And we have some of them in Lagos, in Lekki. I won't mention their names. So venture funding, capital funding has helped them in acquisitions. So basically it is time, but how can they make it work? I said earlier this year, all our providers virtually came to us and said, we cannot work with this tariff. The cost of, we don't even have GSK products anymore. Augmentin is out of it. So we even had to set up a pharmacy-based network where we are now the ones delivering drugs to our enrollees with chronic diseases because they could not get all the medication. But what are we saying? When there's tax holiday with importing and forex issues, when hospitals are exempted, even from this power issue, hospitals are on band A and you want them to treat emergencies, how would they put on the light? That's why some will be operating with candle lights. So can the government give them some tax breaks, even with importation, even with consumables, even with drugs, so that we are not paying what the private and the other people are paying? There's some form of tax holiday, there's some sum of incentive to help and encourage the private sector to thrive, because doing it needs a lot of capital. And when the capital is not there, even when they come together as a merger, they need these tax breaks. Recently, even through the Healthcare Federation, Ms. Cindy Lee leadership, we're trying to get a bill where they will be exempted from some import duties.
Taxes, yes.
And then some bulk purchases is being encouraged amongst private sector, so that instead of buying, we're all coming together, buying in bulk and getting some reduction. But we need those tax breaks from the government. With light, independent power sources, with consumables, with all the imports. Drugs, foreign exchange, it's no longer affordable for the average person. And as an HMO, AXA Mansa, we have had to do the import ourselves, and now we're giving our enrollees drugs directly to their houses or to their offices.
Excellent. So, Dr. Jonathan, what we're saying is that there's strength in numbers when it comes to rethinking how we finance on the private side. The traditional cottage model, the family model, where it's one man's hospital, is his own wife who is the matron, is his daughter who is the accountant, that model has to transform. We should be looking now at hospital chains with 1,000 beds that can negotiate with the strength of 1,000 beds, that can purchase with the strength of 1,000 beds. That's how we bring efficiency into how we run on the private sector. And the private sector we can't ignore because they provide healthcare for more than 60% of Nigerians. So until that dynamic changes and we're all moving to the public sector, we just have to bring more efficiency into the private sector. I'm going to close with my question to to Mrs. Oguyemi. Yes, you can pass the microphone. I know you're representing her, and she's also represented by the SSA here today, I guess, in some way. So this is a question for government as a policy maker. The federal government in 2023, I think in November, they launched the sector-wide approach to financing and managing healthcare. Initially, I will tell you the truth, I was skeptical about putting all the money that comes into Nigeria into one basket and then having to run from there. But 2 years after launching that policy, we're beginning to see the results of that laser focus of saying that we want to see where the money is going, we want to see what is being spent on, we want to document the results. So it's one program, one basket, one report. And now they are reporting improvements in maternal health, they're reporting improvements in perinatal health, improvements in staffing, even human resource, they've been able to do. So I just wanted to find out in terms of financing for Lagos State, is there a similar plan to harmonize, to streamline, to harmonize the way that facilities are financed in Lagos State to have a focus
that brings the kind of results that we've seen with this sector-wide approach at the federal level.
Thank you very much, Dr. Obade. My name is Moyo Sori Adejumo. I am Commissioner 3 for the Health Service Commission and privileged to represent the Special Advisor, Dr. Guyemi, at this forum. Ladies and gentlemen, when a health system takes care of the vulnerable, a health system that works for the vulnerable will work for everybody. And why do I say that? We have enough data, enough information, enough statistics to know that 60 to 70% of the health disparities and inequities happen between or within vulnerable groups, defining vulnerable groups by demographic characteristics or geographic location, social determinants. So when government or health system takes care of 60 to 70% of that disease burden, it's good for all of us. The health disparities are reduced, the inequities are reduced. Back to your question, I just needed to say that. And also, I believe it was Dr. Jadi Solaido that spoke about the budget for health for 2026 in Lagos State, 338 billion from a total budget of 4.2 trillion. That gives us 9%. So yes, we are not quite where we are, where we want to be at that 15%, but we believe we will not in 2026 be where we are right now. And you can only get better with commitment of government and sustainability, political sustainability. So back to Dr. Obade. I don't know, maybe there'll be some people in this room. About 15 years ago, you know, when you go to the National Council on Health, the highest decision-making, policy-making body for health in the country, Lagos State had its own council, investment council, and we called it the State Council on Health. I believe some of us here would recall that. And it was just a replica of the National Council on Health. Budget, civil society, and we'll sit down and fashion out a framework as to how government will proceed in ensuring that health is optimum and available and sustainable and accessible for the residents of Lagos State. So somehow or the other, government dropped the ball. But I am informed and I believe that that State Council on Health, by whatever name we want to call it, be it an investment council, we also had the Donors Coordination Forum.
That's true.
The same government, public-private partners, CSO would meet and fashion out a way forward for Lagos State. So through that forum, I believe that something similar to the kind of alignment that SWAP has will also be what Lagos State will be pursuing before the end of this administration.
What all the activities of health in Lagos State
as much as possible.
Progress that the state is making
and to be
in
trackable,
terms of health.
because we now have our ship. Our ship was launched.
Fantastic.
It was launched last year, and according to the Honorable Commissioner for Health and the Special Advisor, before the end of this administration, the ship will set sail. And I believe we all know what the ship is. It's a data-driven platform to ensure that patients and providers are interfacing, storage of EMR,
that's been launched, right? It has been launched already.
Yeah, but state is still uploading data from the public sector.
Yes.
I believe we're about 30% complete. Then we will upload whatever necessary data. So it has been launched, but it hasn't set sail. It will set sail next year.
So the ship is still in the dock, but it will sail.
Getting ready to set sail.
Fantastic. We thank you so much, panelists. It's been interesting. It's been vibrant. We can't close this discussion on rethinking how we finance health in Nigeria without speaking about development assistance. That's been a big part of how we run our health system, how we finance, they determine the programs that we prioritize and all of that. So I'm going to give that to Mr. Ngbedume on development assistance, I mean, that whole landscape is changing. It did not change with Trump. People get that wrong. It had been changing slowly before Trump. But I think the personality and character of Trump is that he doesn't do anything quietly. So when he brought his own, it was with a lot of noise and drama. But before USAID closed this year, several other agencies had closed quietly before that happened this year. So here's my question. For a continent that has been weaned and has grown up on this milk of development assistance, I don't see us not having it in the next 20 years. How do we reposition ourselves, Nigeria, for example, to be attractive in some way to other donors to continue to invest in our health system? Our vaccine, for example, our vaccination program, heavily donor-based. You look at our pharmaceuticals, 95% of what we use as pharmaceuticals is imported from other countries. Look at our technology, it's not technology that is located within Nigeria. So we're not moving away from donor assistance in the near future. How do we continue to access development assistance? And that's our last question. Madam MC, that's the last question. And then we'll take questions from, do you have all those questions put together? Please, if you have a question, please let the MC have it. I think she's coordinating that session. So, Mr. Ngwedeme, how do we continue to make ourselves attractive, qualify for development assistance, and not minding that it's dollar, it's dollar we're talking about is the king of currencies right now. We can't just shut that off.
Yeah, very, very important question and timely too. Yeah, so the reality is that donor funded support, in terms of donor funding precisely, is beginning to decline. That's the reality. And of course, when Trump made that policy pronouncement, it hit, some notes that are not so comfortable, not only in Nigeria, but across the whole of Africa. I think the focus should be more on working towards being independent.
A capital subsidiary as well that deals with advisory for your business. If you have a small business, we can give you financial advisory on what to do in order to improve your business, be it small business, or even if it's not a small business, we can cater to that too. We also have Orange One. I mean, like I said, it's a financial institution. It's very broad. So whatever it is, whatever financial need that you have, we always have an answer to it. It's not one cap fits all. If what I've mentioned is not what you want, we can always bring up something to suit your need. Yeah, I was talking about Orange One as well. I'm sorry there are no slides. I mean, we didn't know we would have to project. We have the Orange One subsidiary that gives out loans. So if you need to start a business and you need a loan, Orange One can give you a loan at a very minimal rate so that you can make use of the loan that you have requested for. We are somewhere outside. We have a stand outside. So, I mean, we have just 10 minutes to speak about what we do. So you can always come to our stand when the session is done, and then we can take it up from there. Thank you so much for listening, and thank you for your time.
Homeless chests to keep fetching money from. At some point, they're going to cut off. And why is the donor fund even coming? It is coming to help us build our own.
Thank you so much, Investment One. Please clap for them. They are our sponsors. Please visit their stand outside and find out more about them. Tech on Oil Services, do we have them in the house? Okay. Aphpn Group, please, your representative should come forward. A round of applause for them, please. These are our sponsors. Oh, we appreciate you guys.
Good morning, distinguished ladies and gentlemen. My name is Ekimuna Soyo, Harriet Domospif, and this is my colleague Ayola Shemowo. We are representatives of Aphpn Group, and we're here to just give you a brief introduction to the products and services that we offer. But before we proceed, we just first of all like to thank the Association of Public Health Physicians of Nigeria for this opportunity to present our products and services, and to also thank them for the work they've been doing in the public health sector. So I will just dive into what we do. We are a one-stop financial institution registered with the Securities and Exchange Commission as well as the Nigerian Exchange Limited. We provide world-class financial services to corporate entities, to the public sector, as well as individuals. Our group commenced operations in 2004 with Aphpn Asset Limited, and over time we've grown companies, Aphpn Capital and Trust Limited, Aphpn Wealth Management Limited.
Thank you very much, Mrs. Adeto, representing Dr. Manuela Zamba. Thank you very much, Dr. Adisola Idowu, representing her very self from
as well. So our brand is now one of Nigeria's most successful financial institutions, and we are now very influential in the country. Our services include securities trading and corporate finance.
Esegine Jonathan, Chairman, Lagos State, representing the National President.
While they were speaking on funding the public sector, a lot of ideas came into my head because we have an issuing house license, and we can also give advisory on how funds can be raised in the capital market. So you can always reach out to us, provided you can have, the reach, especially if the government is also involved in it. You can reach out to us, and then we can package something for you, so that way you can raise funds in the capital markets. We have trust services where people can come to us, and then they give us instructions on how they wish to handle their assets, for their beneficiaries. We have fund and portfolio management, wealth management, registrar and investor services, amongst other things. So beyond the services we render to the corporate and public sectors, as well as ultra HNIs, we recognize that there's a need to make our solutions accessible to individuals, everyday Nigerians. And because of that, we've created retail products that everybody in this hall can also take advantage of, outside of this association. So at this point, I'll hand over to my colleague, Ayola Semowo, so that he can give you some insight into some of our products.
Good afternoon, everyone. So we're starting with our fund management products. We have for individuals, companies, from about 1 million naira. If you want to do termed deposit for 3 months, 6 months, and a year, we have various packages for you. We have the Naira products. We have Sharia compliance products. So that's the Aphpn Wealth Halal investment products, where if you don't want interest-based investment, we do Sharia investments. We have dollar investments also for those that want to hedge against our Naira risk. We assist in buying treasury bills also for 3 months, 6 months, and a year. So, and some people, they don't want the stress of that. They want whereby we would create a discretionary or non-discretionary portfolios. So these are for high net worth individuals, where you bring a large sum to us. We would break it into various asset classes for you, and would meet your needs. So we also have the Aphpn Money Market Fund, where as little as 50,000 naira. If you want to invest for 3 months, then it would move for the. Can you move to the next slide, please? No, the next one. Next one. Yes. So just low risk. So rather than leave your money in your bank account, you could invest in our fund. You can access your money anytime you need it, and we also have our application. So you could go to the Google Play Store or the various app stores, search for April, and you could onboard. So then we have so many people. We have elderly people that have bought stocks in the past. I know the government spoke about billions of nairas in dividends that haven't been claimed. So we can help you with our registrars and our stockbroking license. So we'll do a global search for you where your name pops up. We'll help you get those dividends. So we'll consolidate it, bring it into our house. Then if you want to sell the shares, if you want to claim your dividend, we also help with that. So we'll be here for some minutes. So if you need any help with that, thank you very much.
Thank you so much, APEL Group. Do we have Tech and Oil Services, Diamed Multi-Specialist Hospital? Any representative from Diamed? Okay. Please enjoy your tea break. When we're done with tea break, in the next 15 minutes, we'll be starting the next session, the opening ceremony. Okay. Our Aphpn chairman is reiterating that we should please scan the barcode and fill the Google forms, register, join the association, and pay your dues. Thank you. So kindly scan the barcode, register if you're not yet registered, fill in the required information, and kindly pay your dues. Thank you.
khululeka kumusothina.
Good afternoon. It's afternoon in case you don't know. You don't know. Okay, good morning. For those of you that still want us to be in the morning, good morning. But actually, we are in the afternoon. So good afternoon, distinguished professors, public health physicians, our guests, and of course, our esteemed members that are joining online. You are welcome again to day 2 of 2025 Biennial of the Association of Public Health Physicians of Nigeria, Lagos chapter. It has been wonderful. The first panel section has been great. And very shortly now, we'll be moving in to the opening. All our guests are around and are close by. And I want to tell you that we are in here for a good cause. Without wasting much time, I just want to remind us, if we had forgotten who we are, as Prof told us, that we are member of Association of Public Health Physicians of Nigeria, distinguished crop of doctors that knows their onions. We are unique because we don't treat only our patients, but we treat the community. We treat the nation. We influence policy. By looking through all things, we are a set of people that think outside the box. We believe there could be more than one way to do whatever we needed to do and still get results. So I want every one of us to give ourselves a round of applause for being part of this distinguished set of doctors. I've always been proud to be a public health physician. I don't know if you are not. I am proud to be a doctor first, but to be a public health physician is like adding a feather on my cap. Especially when I see people like Professor Shibogun, I am so thrilled. When I see people like Professor Nojole, I wonder. And when I see Professor Abosede, I know that I am in the right clique. And of course, I cannot but talk about my wonderful professor, Dr. Odeyemi, Professor Odeyemi. She drilled me, oh. Ọlọ́run o, ayé o. When I was doing my MPH, I was lucky to have her as my supervisor. So while I was lucky, I was thinking I was unlucky. Because other people, when they write whatever they wrote, their supervisor will say, continue. But when I write all that I think I know, Professor Odeyemi will see the I that I did not dot, the T that I did not cross. I don't know how she saw it. So when I come out of her office, I will be looking sad. But I want to tell you, I'm a better person when it comes to research. At least, even that I am not a professor, when I see people saying that they have problem with their thesis, I will say, thesis ole. Then I will remember all those things that Professor Odeyemi taught me. Prof, thank you, ma. I don't know if you are thanking all your professor and your supervisor. When you start with them, at times you don't like them. I remember crying to Professor Kuyinu, and I told her, now. And she said, I said, mi ò tiẹ̀ ṣe mọ́. Ṣó yẹ kó le tó bẹ́ẹ̀ yẹn ni? Kí ló dé? She now said, oya, jókòó. And as she was explaining it, I now know why she's a professor. I am not yet. But when I grow up, I know the people that I want to be like. At least I want to be like Professor Shibogun. Give him microphone anytime. He's talking. Cerebral. Correct. Articulated. Which other one? Calculated. Computerized. So I'm sure we are rounding up our tea break. Our ushers, please let's start clearing the table. And I will appreciate, please, if we can step forward, except for the table in front, so that we can make our pictures and our ambience beautiful when they are taking the video recording. So those people at the back, please let's just step forward, just one table, and fill it, and let the table be well filled. Those people that come late, except for the ones in front that we reserved for our special guests and other guests that are coming in. So thank you very much for tolerating my nonsense. You're welcome.
The rain had washed the streets so clean, a quiet peace, a silver sheen. I walked alone, my head held low, with nothing left, nowhere to go. But then I heard a song so kind, it stirred the hope I left behind. And through the dark it called my name. I found my faith again. Found my faith again tonight, in the warmth of mercy's light. Through every wrong, through every pain, I found my faith again. No more lost in where I've been. I found my faith again. I'd cursed the sky, denied the truth, chased the wind since restless youth. But now I see what love can do. It brought me home and made me new. No choir sang, no thunder came, just quiet peace that spoke my name, and when the silence touched within, I found my faith again. Every wound, every sin led me where life begins. Heaven whispered from within, and I found my faith again. Oh, found my faith again. Now my soul can breathe again. Ooh, now my soul can breathe again. We walk through years of silent pain, through laughter lost and love regained. But tonight when your eyes found mine, the spark returned, the stars aligned. The way you smile cut through the haze, like sunlight through forgotten days. It's not the words, it's what I see, the way you look at me, the way you look at me.
Good afternoon again. Once upon a time, there was a man, influential, rich, and he had a ball. Fortunately and unfortunately for this influential man, the man's wife was an illiterate, so she does not know what it means to attend to people at gathering. But the man had a ball, and so people came. And the wife came out in a fine apparel and was greeting them, one from the other. She was greeting them. And the husband noticed that everywhere she went, they will laugh. And so the man called, "What were you telling them?" He said, "I was greeting them." "How did you greet them?" He said, "I said, I am great." Ha! I am great. It's not what they said. They said, "I am grateful." He said, they said, "I am grateful." Only okay. So the woman went out again and started going from one person to the other and said, "Great ekan, full ere." Great ekan, full ere. Because the husband said, it is, "I am grateful." So since she did not give them the food, she came back to give them, and she told, "Great ekan, full ere." So why am I saying this? I think when I came out, I did not greet some people that I was supposed to greet. So in case I break, I murder protocol, forgive me. So I will use this option again to start saying, great Ekan. I am grateful to have every one of you. The LOC of 2025 Association of Public Health Physicians of Nigeria Lagos Chapter is very grateful for you attending this August gathering in December. And in case you don't know, we are in December. And today is the 4th of December. Christmas is just round the corner. And I'm sure it shall be a merry one from every one of us as the Lord God Almighty live. So thank you very much. I appreciate all medical officers of health, all retired and not tired members of the Association of Public Health Physicians that are here, all doctors from our general hospital, all doctors from the NGOs, all my friends that work with all those gym partners. I want to say thank you very much for being here. By next one, we will be more than this. So those of you that have done MPH, and for one reason you have not joined the association, please, we have a barcode. Join the association. Please, join the association. Thank you very much.
Thank you very much, Ma. So should I take that we have established the protocol? Okay. Good afternoon, distinguished ladies and gentlemen. This is the moment and hour that we have been waiting for. So we shall be starting the opening ceremony of this great scientific conference. So, do we have the national anthem? Okay.
Nigeria, we hail thee, our own dear native land, though tribe and tongue. Nigeria.
Representative of the Deputy Governor. Representative of the Honorable Commissioner for Health, Professor Akin Abayomi, in person of Dr. Fumi Adeboche. You're welcome.
the Senior Special Assistant to Mr. Governor on Public Health, Dr. Tony Adeyemi, who is one of us. You're welcome. We also have here, oh, pardon me. We have here the representative of the Special Advisor on Health to Mr. Governor, Dr. Kemi Oguyemi, who is ably represented here by our very own Dr. Moyosare Adejumo. You're welcome, ma. Pardon my error. We have here also Mrs. Adetoro representing the Permanent Secretary of Lagos State Health Management Agency. You're welcome, ma'am. The chairman of the program, Professor Akin Osibogun. You are welcome, sir. The chairman of this noble association, Professor Yetunde Kunyinu. You are welcome, ma. The keynote speaker, Professor Adesegun Fatusi. You're welcome, sir. We have some of our medical directors here present. You are welcome. Directors from the Lagos State Ministry of Health. You're welcome. Our very own retired but not tired dignitaries here. We appreciate you all. You're welcome. We also thank all our colleagues in the academia. Those that are not in the academia, we welcome you all. We welcome all our teachers, our mentors, everyone here, all seated. Distinguished ladies and gentlemen, you are welcome. And this program started yesterday. And you know, we had our speakers, Professor Osibogun. You know, he spoke to us, he gave us a lecture. We also had a lecture from Dr. Sholak Pison. We had abstract presentations. And in all, I looked around and I said, thank God for my professors in public health. You know why? They make things so simple. Simple. 1 + 1 is equals to 2. 1 × 1 is equals to 1. That is the professor, all our professors in public health. The likes of Professor Nojole, Professor Roberts, Professor Ololade Wright. 1 + 1 is 2. I started appreciating my professors when I went to the Faculty of Engineering. My son had one issue, so I went there to see a professor. When I got there, by the time we were speaking, guess what? 1 × 1 is what? 11. As how? How now? 1 × 1, 11. Because by the time he finished analyzing and telling me, in fact, that day I knew that complication, convolution, difficulty has grades and shapes and different faces because I had everything. I had difficulty with speaking because he said, do you agree 1 × 1 is 11? What will I say? Of course now, because I was pained. So when you have the opportunity, please take a picture with our professor, our elders in this public health. Public health, in fact, I don't know what else I would do if not public health. I thought I would do psychiatry. That one is story for another day. I went there for a posting. I came back, my life was not the same. Because if you hold mic in a certain way, they will say 5 minutes something. Don't let me say. So, distinguished ladies and gentlemen, your 1 + 1 is what? And your 1 × 1 is what? Now, we are moving on. So next up on the agenda is to give us a welcome remarks by one of us. Although we have the former chairman here, the previous program, this very program. I remember her, what she did. She was the one that made us to be having 2 days, you know. But right now, let me invite Dr. Alex Oko, a very wonderful person, our mother.
our mama, pretty mama. You are welcome, ma. We are ready for your welcome remarks.
Thank you very much, Dr. Nire. If you believe her, you believe anything. So, good afternoon, ladies and gentlemen, Your Excellencies, distinguished ladies and gentlemen. Please permit me to align with the very well-established protocols by Dr. Onire. I have a very simple task this afternoon, and it is to welcome you to the opening ceremony of this conference. So it is with immense honor and heartfelt enthusiasm that I welcome you to this pivotal gathering, the opening ceremony of our 7th Scientific and Biennial Public Health Conference, themed Global Health Under Threat, Advancing Sustainable Financing and Workforce Capacity for Equitable Healthcare Delivery in the Global South. This conference has been convened at a critical juncture. The world is facing unprecedented health challenges, from the lingering effects of pandemics and climate-induced health crises to widening disparities in access to care. Nowhere are these challenges felt more acutely than in the Global South, where fragile health systems, underfunded infrastructure, and workforce shortages continue to undermine the promise of health equity. Today, we gather here in Nigeria, a nation of resilience, innovation, and untapped potential, to confront one of the most pressing challenges of our time, the growing threat to global health, and the urgent need to strengthen our systems for equitable care as we grapple with the ripple effects of the withdrawal of foreign aid and donor fatigue amidst the convergence of crises across the Global South and indeed within our own borders. This conference is not just a reflection of the threats we face. It is a declaration of our collective resolve. We are here to forge solutions, to share innovations, and to build partnerships that transcend borders and disciplines and sectors. We are honored to have in this room the very leaders who shape policy, drive research, deliver care, and invest in the future. Your presence signals a shared commitment to building a healthcare system that is not only resilient, but equitable, inclusive, and sustainable. Today, we continue to explore transformative strategies for sustainable health financing, examine models for strengthening and retaining the health workforce, leveraging public-private partnerships to close the equity gap, and redefine the role of public health physicians and elevate voices from communities that have long been marginalized in global health discourse. Let's challenge assumptions, celebrate resilience, and co-create pathways towards a future where healthcare is not a privilege but a right, accessible, affordable, and equitable for all. Let this be a space of bold ideas, brave conversations, collaboration, and clarity. Let us listen intently and determined to leave here not only better informed, but inspired to act. And so on behalf of the chairman, Aphpn Lagos chapter, Professor Yetunde Kuyino, and the conference organizing committee, I thank each of you for your presence, your expertise, and your unwavering commitment to advancing public health by answering the call to lead in these times of uncertainty. Together we can, and we will, reshape the future of global health. Welcome to the conference. Ladies and gentlemen, Your Excellencies, let the work begin. Thank you.
Thank you very much. That's our Mama LOC. And of course, we have somebody walked in here while the chairman of the LOC was presenting, and that is Dr. Alex Huko.
the husband of, yes, the husband of our chairman of the LOC. You're welcome, sir. Thank you very much. And I just want to use 1 second to appreciate Dr. Obade. Thank you for all you do. Thank you for the foundation you laid. And that is what we are building on. Thank you very much. So up next now, I want to invite another professor that believes that 1 + 1 is nothing but 2. And 1 × 1 is nothing but 1. If she asks you 1 + 1, you know that students at times want to say 1 + 1. You know, the one we go like this, the one we go. She doesn't want that. Just tell me 2. So now I call upon our very own chairman of the Lagos chapter, beautiful Professor Yetunde Kuyino. She's glittering. Please, a round of applause for my professor, for the chairman of this great and noble association. You're welcome, ma.
Good morning. I call you my family. Good morning, family. Are we one family? Aphpn Lagos, we are one family. Our special guest of honor, Her Excellency, Dr. Ebijoke Kaduna Sanwo-Olu. I've seen one of the protocol. She's sending someone to represent us. That she would have loved to be here, but so I have so many things to do. So I've seen the protocol. So I believe that the person on our way, before we finish this opening ceremony, the person will get to us. The wife of the Deputy Governor, Mrs. Amzat, represented by one of us, Dr. Rolambo. Thank you for coming. Dr. Adeboye, representing our Honorable Commissioner for Health, Professor Akin Abayomi. I know that you would love to be here, and I know that there are a lot of things being done at the ministry right now. Pharmacy Moyosori Adejuma. She's my lost friend and found. She's representing Commissioner, she's Commissioner 3 at the Health Service Commission, representing the Special Advisor, Dr. Ogunyemi. Our PS Lashma, being represented by Dr. Adetoro. My Egbon and teacher and mentor, the chairman of this occasion, Professor Akin Oshibogun. You are welcome, sir. My friend and brother, the keynote speaker, all the way from Ife, Professor Segun Fatusi. You are welcome, sir. Thank you for coming. Our medical elders, Professor Abosede, you are welcome, ma. Dr. Agbe David, you are welcome, ma. We appreciate you. Dr. Mosoya, my auntie, you are welcome. All the medical officers of health that are present here today, our directors from Ministry of Health Service Commission, esteemed resident doctors from Lut and Lasut, all our colleagues from other institutions that are here today, our teachers, our mentors, the institute guests, esteemed colleagues, ladies and gentlemen of the press. You are welcome to this 7th Biennial Conference since Aphpn was inaugurated, Lagos Chapter 2013. It's my great pleasure and honor to welcome you to the Biennial Conference of the Association of Public Education of Nigeria, Lagos Chapter. Today we gather to discuss the theme, Global Health Under Threat, Advancing Sustainable Financing and Workforce Capacity for Equitable Healthcare Delivery in the Global South. The theme we have chosen could not be more timely. Across the world, and especially in the Global South, Health systems face significant challenges, from emerging diseases to rising non-communicable conditions, from financing gaps to workforce shortages, especially with the jackpot syndrome. Our health systems are under pressure. This conference is an opportunity to examine these challenges, share ideas, and develop practical solutions. First, we focus on rethinking sector investment. Under the sub-theme, rethinking sector investment, a call to paradigm shift towards equitable and sustainable approaches. Too often, health financing emphasizes short-term programs rather than long-term sustainable approaches. Today, we will explore innovative models such as social health insurance, as proudly championed by LASHMA in Lagos State. Public-private partnerships and results-based financing that can make healthcare more equitable and sustainable. It's a call for us to think differently to ensure that resources reach those who need them most. Now, second sub-theme, we will examine innovations in health system strengthening. Digital health, telemedicine, and artificial intelligence are transforming healthcare delivery. These technologies have the potential to bridge operational gaps, improve diagnostics, and extend care to underserved populations. In Nigeria, where health infrastructure is often stretched thin, embracing this innovation is not a luxury, it is a necessity. By integrating technology into routine health services delivery, we can overcome geographical barriers, reduce operational inefficiencies, and enhance patient outcomes. Furthermore, AI and data-driven approaches can inform policy decisions, predict disease outbreaks, and optimize workforce deployment, ensuring that limited resources are used strategically for maximum impact. As public health physicians, we must champion these tools responsibly, ensuring ethical use while maximizing their impact. Finally, we will discuss the postgraduate fellows program and its gains for the health sector. The postgraduate fellow program is more than an academic pathway. It is a strategic investment in human capital, equipping public health physicians with skills, knowledge, and leadership capacity required to address complex health challenges. Fellows emerge not only as clinicians but as researchers, policy makers, and system leaders, capable of designing and implementing evidence-based interventions. I also want to recognize the Lagos State chapter. I would like for us to project the barcode. As I'm recognizing Lagos State chapter, the executive, the local organizing committee, our sponsors, media, please, our speakers, our delegates. Your dedication has made this conference possible, and your presence reflects a shared commitment to advancing public health in Nigeria and across the global south. In closing, I once again warmly welcome you all. May this conference be a space for learning, inspiration, and actionable solutions. Let us work together to strengthen financing, build workforce capacity, embrace innovation, and create resilient health systems that leaves no one behind. Thank you, and welcome to the conference. Thank you so much. I want to say that, please, I want all delegates to scan this and fill the Google form. Aphpn, we have a large heart. It's not meant for only fellows. If you're a medical doctor, you have MPH, and you are practicing the public health space. You are one of us. So as you fill this Google form, there is a section that says that, are you a member? If it is no, please can you fill yes, I want to be a member, so that we can get your details. Remember to put your institutions, so that we can get to you. And if you are a member and you are yet to pay your dues, please, the account details is there. Can you just do that in a jiffy? Thank you very much. God bless you as you do that.
Thank you very much, Ma. So you see, 1 + 1 = 1. And let me quickly tell us, please, to be a member, please, you need to be a financial member. Dr. Babalola is outside to collect your money. And we have the account details there. You know, how will the children feel? You have come for 2 days and you are a member and you are not paid. You say, Mommy, Daddy, why now? Why didn't you pay? I'm sure you don't want the children to ask you that, why have you not paid your dues? So please, let's pay our dues. They are outside to collect the money, and then don't forget to fill this form as well, please. Right about now, I was informed that the representative of the First Lady of Lagos State, Dr. Mrs. Claudina Ibijoke Sanwo-Olu, is here. She's ably represented by Mrs. Mustafa, the wife of the Permanent Secretary, Primary Health Care Board, and Member Committee of Wives of Lagos State Officials. Mrs. Mustafa, you're welcome, ma. Thank you very much for joining us today. Thank you so much. This is the Association of Public Health Physicians of Nigeria, and we are glad to have you amongst us. So right about now, I want to call upon another professor to give us the opening remarks. Before then, permit me to introduce another person that walked in, our very own, one of the permanent secretaries of the health districts. I speak of no other than Dr. Omololu, the permanent secretary, Health District 6. Yes, Health District 6. You're welcome, sir. Thank you very much for all you do. So I want to call upon another professor. Believe me when I say 1 + 1 = 2. Don't go to the left. Don't go to the right. When he asks you 1 + 1, don't try to use all these board mass, open brackets. Just tell him 1, and you will score 100/100. He's a mentor, our teacher, a big masquerade in the field of public health. I know you know the person I'm talking about. I speak of no other person than our very own Professor Akin Oshibogun. You're welcome, sir. We are ready for the opening remarks. Thank you very much, sir. He is the chairman of this occasion. You're welcome, sir. And congratulations.
Very much, Dr. Nire. The representative of the First Lady, Dr. Claudina Ibijoke Sanwo-Olu, ably represented by Mrs. Mustafa, the representative of the Commissioner, representative of the SA. Kindly permit me to just adopt the protocol that has been well established. Now the ladies have been speaking, and now it is a tough challenge for me to come and speak after them. You know, their voices are more pleasant to the ears, and my own voice, I'm sure, is croaky. You know, so, but just take me as you see me. Let me start by commending the organizers of this conference under the leadership of Dr. Alice Oko. She's done a very wonderful job. Let me commend our state chairman, indefatigable Professor Puyinu.
think it is very important that associations such as ours must organize meetings such as this for two main reasons. The first reason is that it affords us the opportunity of meeting together so that we are not professionally isolated. Because if you are professionally isolated, there's a tendency that you can persist in your own errors and keep on making your mistakes. But when you meet with your colleagues and you exchange ideas, then you are up to date, you know what is the current practice in the field. That is one objective of meetings such as this. And of course, some of us have also been involved in research, so we have the opportunity of presenting the latest findings in the field. So we are extending the frontiers of knowledge. So these meetings are very important, and I'm excited that I'm able to be here. The second very important reason, or third important reason for these types of gathering, is that we should direct policy. We should be able, at the end of this meeting, come out with positions and advise governments at all levels as to the directions they should take. It's a pity Nigeria is well endowed, the resources are here, and yet the people are living in poverty. That is an indictment of all of us. It's either because we are not giving the right advice to governments. In terms of resources, in terms of land space, we've not cultivated 20% of our land, and yet people are hungry. It doesn't make sense that you've not cultivated 20% of your land space and people are hungry. But coming back to the health sector, you then look at the vast amount of money that is available, even in the NHIA. And then if we talk about the NSITF, the National Social Insurance Trust Fund. So money is just lying down there, and yet we are not having the infrastructure that we need. So if my little intervention this morning does nothing, is to probably speak the truth to all of us so that when you meet your friends in the evenings where you meet, you will tell them what to do. This association should be able to advise policy makers. So those funds are there, and those funds can be deployed to provide very low interest loans to energize the private health sector. So the primary responsibility of government is not necessarily to provide services. The primary responsibility of government is to ensure the availability of services. And there are different tools that can be used to ensure the availability of services, including direct provision of services or purchase of services from the private sector and granting soft loans to the private sector to provide needed services. And I'm not talking theory. That is the model that India adopted. The biggest hospitals in India, they are not public hospitals. They are private hospitals. And what the Indian government did was to provide a specialized fund to be able to provide the loans to the private sector so that they can then provide Apollo Hospital, all those big names that you hear of in India. They were funded by the Indian government at very low interest rates. And the Indian government probably has some 5 or 10% shares in them. That's about it. So the themes of our conference has been around that, financing the health services. So I just thought I should chip that in. And then, of course, also to let us remember that there are social determinants of health. The GDP, we say, is the biggest in Africa, and that's a plus. You must generate the wealth. But as I said, we are not even generating enough wealth. You take cocoa from West Africa, you buy it at $1, you bring it back as chocolate at $20. So there's room for us to think. So we have the cocoa, they take it from here and bring it back to us at $20. So as public health physicians, we are not just thinking about azithromycin and so on, we are thinking about the whole picture. And that is what has been happening since yesterday. So I must commend all the speakers, and I'm sure that Professor Fatusi is also going to energize us further this afternoon. So I welcome you most sincerely, and I look forward to our challenging ourselves and telling ourselves and telling our country the truth so that we can all make progress. Thank you, and have a pleasant afternoon.
Thank you very much, sir. So, 1 + 1 is what? Okay. 11. My PS, sir. Well, you were not here when I told them of the, are you part of, no, you're a public health physician, sir. So while the chairman of this occasion was speaking, we had some of our permanent secretaries, they came in. We have Permanent Secretary, Health District 5, Dr. Dapo Ashinobi. He's one of us, yes. And also we have another of our permanent secretary, in fact, a very beautiful mama, our very own, my former director, Permanent Secretary, Health District 2. She's one of us. Thank you very much for coming. We appreciate you. Yes, we are moving on to the goodwill messages, and I want to invite Dr. Fumi. I've introduced Dr. Mololu. You are welcome, sir. I'm greeting you again. Because I know that when I see one, I know I must see 4 at least. Okay, thank you very much. So we are moving on to the goodwill message right now. I want to invite Dr. Fumi Adeboje, who is representing the Honorable Commissioner for Health. And let me tell you, ma, we've had series of presentations from research, and you heard what the chairman of this conference said, that we are taking our topic, what our findings to town, taking our gown to town, converting it to policies. And this conference is basically for us to learn, to unlearn, to relearn, and to keep learning. So we want to invite you for your goodwill message. You're welcome.
Good afternoon, everyone. Let me first say that it's unfortunate Honorable Commissioner for Health cannot be here today. This is an impromptu assignment given to me because he actually wanted to be here. I asked to go to the House of Assembly to finalize on the recently signed law of University of Medicine that were established in Lagos State. So that's why he cannot be here. For those that know Commissioner very well, he doesn't like to stand on a 60 proctor. He likes to acknowledge all people that are seated in the hall. So firstly, I would like to recognize the First Lady of Lagos State, Dr. Mrs. Claudiana Ibijoke Sanwo-Olu, ably represented by Mrs. Mustafa, welcome her, wife of Deputy Governor of Lagos State, Mrs. Oluremi Amzat, represented by Dr. Aro, the Special Advisor to Mr. Governor on Health, Dr. Mrs. Kemi Ogunyemi, ably represented by Dr. Mrs. Moyosore Adejumo. My PSs, PS Lashma, Dr. Emmanuel Azamba, represented by Mrs. Adetoro, Dayo Adetoro. PS Ed District 4, Dr. Olufemi Omololu, welcome, sir. District 6, apologies. PS Ed District 2, Dr. Dayo Lajide, you're welcome. PS Ed District 6, Dr. Dapo Ashinobi, 5. Apologies. The Senior Special Assistant to Mr. Governor on Health, Dr. Oluwatoni Adeyemi. The Chairman of the Conference, Professor Akin Oshibogun, welcome, sir. The Chairman of the Association, our able Professor Professor Yetunde Kuyino, and the distinguished keynote speaker for today's event, Professor Adesegun Fatusi. You're welcome. My name is Dr. Fumi Adeboje, an health economist and health financing specialist, also double as a special technical assistant to the Honorable Commissioner for Health. If you permit me, I would like to read the Honorable Commissioner for Health goodwill message. All right. Distinguished public health leaders, esteemed professionals, ladies and gentlemen, it's my honor to deliver this goodwill message on behalf of the Honorable Commissioner for Health, Lagos State, as we gather for this biennial and scientific conference of the Association of Public Health Physicians of Nigeria. The theme for this year, Advancing Sustainable Financing and Workforce Capacity for Equitable Healthcare Delivery. It is both timely and deeply aligned with our collective aspirations for a stronger and more resilient health system. Public health physicians remain the backbone of preventive care, population health management, and evidence-based decision-making. As we confront rising healthcare demand, shifting disease patterns, and the need for greater equity in access to services, your role has never been more crucial. The Honorable Commissioner commends the Association for the consistently providing thought leadership and for driving conversations that shape policy, improve practices, and strengthen Nigeria's healthcare architecture. Lagos State remains committed to reforms that enhance sustainable health financing, expand coverage, and build a skilled, motivated health workforce capable of delivering quality and equitable health care to every resident. At this point, let me pause a bit. While seated in the hall and listening to all the presentation and the panel discussion, it's interesting to note that while challenges will be identified for equitable health care, just about 2 weeks ago, the governor of Lagos State, Mr. Olusola Sanwo-Olu, got approval to launch the health financing reform, which we call Lagos Private Health Partnership. This initiative actually is going to solve a lot of issues identified while presenters were making their position. For instance, we talk about equity in financing. The social health insurance pattern of contributing for healthcare is somewhat kind of regressive. And for us to have a sustainable and robust financing, you must have a kind of progressive financing. So this initiative is actually harnessing the private sector, the potential lying within the private sector to increase fiscal space for healthcare. What is the initiative going to do? The initiative is, as already mentioned, that there are fragmentation in health insurance. Let me start initially that health insurance is actually not the goal of UHC. It's a means to get there. Our goal is to ensure that we have quality care, we have equitable in access and utilization of care, and at the same time there is financial protection. So what LPHP is going to do is that we are trying to establish a kind of unified private health insurance scheme in Lagos State. Because private schemes are operating in silos. Lagos State policy is not for public sector alone. We also oversee the private sector. So there are a lot of problems within the private HMOs. For instance, it was mentioned that there is what we call undercutting. A lot of things goes on in private sector. So as a government, we are not standing aloof and looking at that space. Because whether the private or the public sector, we have to feed into the global UHC goal. So what LPHP is going to do is that to create an integrative kind of pool for all private HMO in Lagos State, such that though it is a private business, but they speak to each other. We create a single pool where funds are being gathered together, and at the same time, for us, because we can, informal sector, which are mainly in the social health insurance space, does not enjoy this effect with the rich, the elderly. They are mainly the participant with the private sector. They don't enjoy that benefit. So the initiative is trying to create a reducible capacity where funds flow from the private sector to the social health insurance scheme, and at the same time feed the global public health space. So for that, we are trying to, that is going to be operated under a digital platform where all plans sold by private HMO are standardized and coordinated under a platform, such that the issue of undercutting, which was explained earlier, is going to be corrected. No HMO will value a plan at 80,000, another HMO goes and sell it at 60,000. We forget that the goal of insurance is to actually provide quality care. And the people that provide this quality care are being shortchanged, which are the healthcare provider, the hospitals. And that's why we have this catalytic effect of lack of human resources due to Japan syndrome. So when all these plans are appropriately priced through actually determined evaluation, this kind of packaging will now be actually sold to the healthcare provider, so that they now have guarantee and the capacity to deliver that package. Because most of the issues that we have, which has been stated, is that they can't deliver that package because it doesn't worth it. Healthcare is not cheap. They use resources. They have to pay human resources for health. So by that, we are trying to solve a fundamental problem, ensuring that we bring wealth to the healthcare facility, for them to actually equip the facility with the appropriate resources, ensure they have engaged human resources for health. All these are going to support in delivery of quality care. So for the initiative, we are trying to create a risk equalization platform. Though the private HMO are not going to be merged with social health insurance. They are going to be on their own, but the system is going to create a means that funds cross from the private sector to the social or to the public sector. At the same time, we are actually harnessing the private sector potential for financing. We've always said that public financing for health is the go-to UHC, but government alone cannot do this. We have to harness the large funds roaming within the private sector, which is not coordinated. So that's what SPHP is going to solve. At the same time, we talk about transparency. This initiative is going to be operated on the platform, where all transaction, operation, and even from the hospital side, the client side, they're able to see what is going on. So there will be transaction on the platform. There will be immediate approval for services, no delay anymore. At the same time, one fundamental issue that is affecting quality delivery of care is that most hospitals does not know when they are going to get their pay, which was mentioned in the presentation. So what the platform or the initiative is going to do is that all services that are supposed to be paid on capitation will be done. For those that deserve to be for fee for services, and for hospitals that have the capacity to deliver on a global capitation, we are going to actually implement that. And at the same time, we're talking about leveraging of information technology. This digital platform is going to rest on SHIP, as has been mentioned by the Special Advisor for Health. This SHIP is a state health information platform. So all activity that has been operating on the platform will be fed into the state SHIP. This is going to help us in ensuring that we have effective use of data for early detection of disease or patterns, and at the same time, we have data to guide us in policy decision. So I'm glad to actually inform this audience that majorly all the challenges that was mentioned about health financing in this gathering is going to be addressed by Lagos Private Health Partnership. So, thank you. So in conclusion, we look forward to outcomes, resolutions, and innovative recommendations that will emerge from this conference. Be assured that the Lagos State is ready to collaborate with professional bodies such as Aphpn to accelerate progress towards universal health coverage and to ensure that no one is left behind. On behalf of the Honorable Commissioner for Health, I congratulate the organizers and wish you fruitful deliberation, impactful engagement, and highly successful conference. Thank you.
Thank you very much, Honorable Commissioner. We are grateful, and of course, we are ever ready to collaborate. And be rest assured, we will share the proceedings of this meeting with you. So for my Honorable Commissioner, 1 + 1 is what? Don't say, oh, don't say the answer. Okay, thank you very much. So the next person for the goodwill message, I would like to call the Permanent Secretary, Health District 6, for your goodwill message. Although Dr. Femi Omonolu is a public health physician by association, but by profession.
Public health physician by association. But when the chairman was talking about filling the form, I was already rejoicing that I'm not a member. Until she now said, if you are not a member, say you want to be a member. And I said, okay, I will say I want to be a member. There is no harm. Then she talked about paying dues. And I said, how much is the dues? And they told me. I said, I will double it. The First Lady, ably represented by Mrs. Mustafa, the chairman of the occasion, Professor Oshibogun, the chairman of the APHP, Aphpn, see, I'm a learner, Professor Kuni, my fellow permanent secretaries, the commissioner, ably represented as well, senior special assistant on health, Dr. Adeyemi. I'm still trying to get this protocol thing going. Other distinguished ladies and gentlemen and fellow physicians in the house. It is a great honor to be here at this your conference today. Oh, sorry, our conference today. You know, it has been a bit of a transition for me because being primarily an obstetrician gynecologist, and when I was informed that now that I'm in primary health care, I'm now a primary health care, a public health physician, I was like, okay, that's a new feather in my cap. I said, am I allowed to put member Aphpn in my degrees or something? You know, so we are still working on that. So maybe I have to go and look for one course in public health to do. But it has been quite an adventure and quite illuminating coming into the public health space. Because when you're at the specialty phase, you actually don't see a lot of things, and you are narrow in your thinking and in your perception of what healthcare means. And I must say that I feel privileged, I feel blessed, I feel honored to actually come into this space because it is widening my scope and opening my eyes to a lot of what goes on in healthcare delivery. I mean, coming down to the grassroots, and I'm looking at things that actually impact on the healthcare of people in general, not just pregnant women, and looking at the reproductive health of women. There are a lot of challenges we still face in this country, as we know, concerning healthcare, and that's why gatherings like this are very enlightening and very educative and informative, where we come to talk and actually look for how we can find ways out. I was looking at some of the topics for some of the abstracts to be presented, and I think there are things I will have to look at a bit more further. Sorry, how frequently do we do our conferences? It's biannual, and I was looking forward to next year's already. Okay, but I'm sure by the time I come for the next one in 2 years' time, I'll be a fully grounded member, and I'll be able to give you a more robust goodwill speech. So thank you very much, and I wish us all a pleasant conference.
Thank you very much, sir. So, for Dr. Femi Omololu, Permanent Secretary, L District 6, is 1 + 1 is what? 1. Okay. Sorry, I was supposed to call on the representative of the wife of Deputy Governor, Dr. Aro, for the goodwill message. Before we... You're welcome, sir.
Good afternoon, everyone. So, warm greetings from an excellency, the wife of the Deputy Governor, Lagos State, Mrs. Oluremi Amzat. She would have loved to be here, but she's unavoidably absent. So I will also want to go through the protocols because she will also love to go through the protocols. So Her Excellency, First Lady of Lagos State, Dr. Ibichuke Sonwolu, ably represented by Mrs. Mustafa, Honorable Commissioner of Health, Professor Akin Abayomi, ably represented by Dr. Fumi Adeboje, the Special Advisor on Health, ably represented by Commissioner 3, Health Service Commission, Permanent Secretary Lashma, Dr. Mrs. Zamba, ably represented by Mrs. Tayo Adetoro, all permanent secretaries present in all health districts, the President, Association of Public Health Physicians of Nigeria, Lagos State Chapter, Chairman of the conference, Professor Oshibogun, Chairman, Association of Public Health Physicians, Lagos State, Professor Yetunde Kuyinu, Chairman, Local Organizing Committee, Dr. Mrs. Alex Oko, all elders present, professors, teachers, medical officers of health, stakeholders in the health sector, government officials present, distinguished invited guests, members of the press, ladies and gentlemen. But please, before I go through our speech, I want to acknowledge Dr. Bisola Adebayo. When I was doing my MPH in Lasut, she was my supervisor. And please, I want to give her a standing ovation and also a clap. Please, on my behalf. Please, on my behalf. On my behalf. On my behalf. Thank you very much. Thank you very much. She really grilled me and scrutinized me to what I've become today. I really appreciate it. Thank you very much, ma. Thank you. Now, the goodwill message delivered by Her Excellency, Mrs. Oluremi Amzat, wife of the Deputy Governor of Lagos State, at the 2025 Biennial Scientific Conference of the Association of Public Health Physicians of Nigeria, Lagos State Chapter. It is a great honor to join the distinguished gathering of public health experts, research, policy makers, and frontline professionals at the 2025 Biennial Scientific Conference of the Association of Public Health Physicians of Nigeria, Lagos State Chapter. I sincerely appreciate the organizers for inviting me to this dynamic occasion and for their unwavering commitment to promoting health and development in our state, Lagos State. The theme of this year's conference, Global Health Under Threat, Advancing Sustainable Financing and Workforce Capacity for Equitable Healthcare Delivery in Global South, is both timely and compelling. As nations continue to navigate emergency health challenges, the importance of strategic health financing, strengthened workforce capacity, and equitable access to care cannot be overstated. I therefore commend the Association of Public Health Physicians of Nigeria, Lagos Chapter, for providing a high-level platform where government stakeholders, academia, development partners, and public health professionals can jointly examine pressing health issues and also propose evidence-based solutions. Your contributions remain critical in shaping policies that safeguard the health and well-being of millions of citizens of Nigeria. And as she has always said, that Lagos sets the pace for health in the whole country, which the Honorable Commissioner of Health has been striving and working hard to make sure that comes to reality always. Lagos State will continue to support initiatives that strengthen primary health care, advance disease prevention, and build a resilient health workforce. We recognize and deeply appreciate the sacrifices of public health physicians and personnel who work tirelessly to protect our communities, especially in periods of global health uncertainty and resource constraint. In conclusion, I would like to congratulate the organizers, facilitators, participants of this conference on their dedication to advancing public health excellence. It is my hope that the deliberation over these 2 days will yield practical recommendations that will further strengthen our healthcare system. Finally, we would like to appreciate the ESCO of this you all a productive and impactful conference. Thank you all and God bless. Igbega Ìpínlẹ̀ Èkó, Ajumose gbogbo wa ni. Thank you very much. God bless you.
Thank you very much. 1 + 1. 1. Okay. Thank you very much. Distinguished ladies and gentlemen, permit me to introduce someone that came in with someone. I didn't quite get the introduction at that time, but I'm well informed. I want to introduce Barrister Kika Alex Oko, the daughter of the chairman of the LOC. You're welcome, my learned colleague. Thank you very much. Okay, so we're moving on with the goodwill messages. Next up, permit me to invite to the podium for the goodwill message our very own Dr. Dapo Asinyobi, the Permanent Secretary, Health District 5. You're welcome, sir. 1 + 1.
Good afternoon, everyone. The representative of the wife of the governor, Mrs. Mustafa, representative of the wife of the deputy governor, and the commissioner, the chairman of the day, Professor Oshibogu, the chairman of the association, Professor Koinu, and LOC, and everyone, body of permanent secretaries, you're welcome. And Aphpn, my colleagues, this is home for me. This has always been home. And that I'm here again in this capacity to witness another conference that I know will be impactful and will bring about solutions that are workable within the health space. It's unfortunate that the only time public health physicians are seen is when there is epidemic. We were the most popular set of people during COVID. I remember. But we don't pray for epidemics. And the funny thing is that when it comes to public health, there's no tape to cut. You cannot cut tape for the number of children you have immunized. You cannot cut tape to the number of maternal deaths you have prevented. You cannot cut tape for the number of lives you have saved promoting wellness. But the figures associated with this, socioeconomic figures, is what gets you happy. And that's why the team of the health financing and workforce capacity advancing is very, very germane at this moment. Like I said before, COVID gave us a very big problem because it opened a bigger door for our health workforce to leave our shores. The global north relaxed their workforce movements when they realized they didn't have enough. And now we produce at cheap rates and they are stolen away at a more economic, viable rate. So we now have to think outside the box. How do we incentivize more to be produced? How do we incentivize those that are here to remain? And those are issues that are primarily beyond the health system. There are socioeconomic factors of pull and push. So when the chairman was talking, he was talking about GDP. Many of us are not interested. He was talking about tax to GDP ratio. Those things don't interest us that much. But these are the real conversations that make this system remain workable. So, for us in the public and primary healthcare space, we should start looking at, okay, if you have immunized this number of children, how many lives has it saved, and what is the financial benefit to the country in the future? When we had diphtheria in Lagos Island and 3 members of a family died, young children, I kept on thinking to myself that these children would have been something bigger tomorrow. How much more will they contribute to our taxes if they become adults and they live our life expectancy of 52 and 55? If they live up to that age, how much would they have contributed? Those conversations are what we can tie to the work we do on the field every day to show government the importance of prevention over curative. And the work starts with us, and we must shout louder than we have ever done before. I wish us continuous impact and better health outcomes for the country. Thank you, everybody. And I didn't want to say 1+1 because I went to Jello Simi, not a kindergarten. Thank you.
Thank you very much, sir. Thank you, sir. So next up, for the goodwill message, I want to invite our beautiful permanent secretary, Health District 2, Dr. Dayo Ibidu Lajide. You are welcome, ma.
Good afternoon, everyone. The First Lady, ably represented by Mrs. Mustafa. Nice to see you again, ma. Representative of Her Excellency. I'll just stand on all protocols that have been observed, but I'll recognize my teacher, Professor Shibogun. I'll recognize Professor Mrs. Kuinu, and I'll also recognize my prof, my sister, Professor Wright. Thank you very much for allowing me to do that. It's great to be here this afternoon. About 2 years ago, when we became permanent secretaries, I was actually very honored because Aphpn was that organization that actually had an event for us as permanent secretaries. And I say a very big thank you to you for that. It was a beautiful one. We didn't ask for it, but they did it. And thank you very much once again. Dr. Molulu is protesting. They're not doing for you. So it's really good to be here and to have public health physicians sit together and discuss. My focus really will be, or my ask will be, to see how we can make the health space a better place for the healthcare workers. I acknowledge that the Commissioner for Health and the whole of the health sector, they're doing a lot in terms of infrastructural development and all of that. But my question is, how can we make this place a better place for our healthcare workers to thrive? Not everyone wants to japa. Yes, there's a socioeconomic factor, which we cannot take away. I understand that no matter the amount that you pay the doctors or the nurses or the community health extension workers, if the environment is not conducive, it's not going to work. But we really do need to look inwards. We need to look at capacity building. And when I say capacity building, it's not that 5-day training or 6-day training. It's encouraging them to learn more, to be open-minded. Dr. Ashinobi said something about GDP. If you go to the health facility and you ask our healthcare workers, what's the GDP of Nigeria? They don't know. What is even GDP? We don't know. You know, and this always shows up when we are having promotion exams, interviews, and things like that. We find that because we're in the health facility, we're kind of boxed ourselves into one corner and we're not looking out to see how we can improve. I'm not going to talk too much, but I'll just ask everyone in the room, whatever it is you can do to build capacity, please kindly help to. Thank you.
Like I said, Dr. Oladide's 1 + 1. 2, simple 2. Thank you very much for that. We really appreciate you. And I can hear Dr. Mololu loud and clear. He's saying, you didn't do for me, oh. He's still saying it. Okay, my chairman is hearing, Professor Kuyino. Okay, so let me invite the last but not the least for a goodwill message. She is one of us. Like she said this morning, that this is my first constituency. So let me invite Dr. Tony Adeyemi, the Senior Special Assistant to Mr. Governor on Public Health. You're welcome, ma.
Good afternoon, distinguished guests, my teachers that are here present, everybody. My teachers are here, the permanent secretaries. I'm just standing on the existing protocol. So I'm not even standing on it because I've broken it already. So I'm just leaning on it. So permit me and forgive me and just allow me lean a bit on the already established protocol. It brings me great pleasure to be here. As Dr. Onire has said, this is my first constituency, my only and my main constituency, actually. So I'm actually happy to be back, not back home, I never left. I'm actually happy to be here among us all. I'm really glad that we're having this conference today. Our theme is very topical. I listened in yesterday and I was really marveled. It was quite an eye-opener on all the issues that we discussed, especially on postgraduate training, something I'm very particular and passionate about. Indeed, we'll be looking forward to the communique that's going to come out from this conference so that we can see how we can advocate, especially for a lot of our fellows. After postgraduate training, we always ask, what next? That's the big question. What next? Especially in Lagos, in Nigeria. What do even our public health physicians, those with masters, especially those with fellowship, where do they go to from there? So I think I must really thank Professor Akin Oshibogo for shedding a lot of light on that topic. A lot still has to be done. I'm glad that Dr. Mabogunje, PS HSC, was here, and then she heard from us, the public health physicians, where the shoe is actually pinching. So it's my hope that once this communique has been drafted, with all our PSCs here present, they'll be able to push this agenda forward so that we can have something meaningful from the communique and even from this conference, and we have action points that we as government can actually work on. So once again, I would just like to say thank you very much for having me here, and then I wish all of us fruitful deliberations. Thank you.
Thank you very much. SSA, 1 + 1. Okay, so we're moving on, distinguished ladies and gentlemen. Thank you for staying with us. Next up on agenda is the address by the special guest of honor, the wife of the Executive Governor of Lagos State, ably represented by Mrs. Mustafa, the wife of the Permanent Secretary, Primary Healthcare Board. So, of course, she's part of us by association, marriage. Either way, she's one of us. You're welcome, ma.
I'm here to represent the First Lady of Lagos State, Dr. Mrs. Claudiana Ibijoke Sanwo-Olu, who is unavoidably absent today. Good afternoon, Honorable Commissioner for Health, Professor Akin Abayomi, ably represented by Dr. Fumi Adeboje, Special Advisor to Mr. Governor on Health, Dr. Kemi Ogunyemi, ably represented by Dr. Tony Adeyemi, Body of Permanent Secretaries here present, Chairman of the program, Professor Akin Oshibogun, chairman and members of the local organizing committee, distinguished keynote speakers, facilitators, and panelists, medical directors of various hospitals and public health facilities here present, directors of the Ministry of Health, medical practitioners from across all fields, gentlemen of the press, distinguished ladies and gentlemen. I'll be reading the address delivered by Her Excellency, First Lady of Lagos State, Dr. Claudiana Ibijoke Sanwo-Olu. It gives me great pleasure to join esteemed colleagues in health sector at this biennial conference of the Association of Public Health Physicians of Nigeria, Lagos State Chapter. This laudable initiative over the years have served as a veritable platform to critically analyze trends within the medical practice, to highlight the various challenges, and further profile lasting solutions to these issues towards improving healthcare delivery in our society. I have no doubt that this year's edition of Biennial Conference will also assist in coming up with intellectually engaging and robust ideas that will translate into development and progress needed results for the health sector. As a member of the medical family, permit me to congratulate the leadership and the entire members of this association for yet another successful conference. The theme, Global Health Under Threat, Advancing Sustainable Financing and Workforce Capacity for Equitable Healthcare Delivery in Global South, is apt as it highlights efforts to achieve universal health coverage. Let me say the advancing equitable healthcare delivery requires a shift from relying on external to mobilizing domestic resources and strategically investing in the local health workforce. It is imperative to emphasize that the health and well-being of all residents is of top priority to the state government under the administration of Mr. Babajide Olusola Sanwo-Olu. This explains the reasons for the various initiatives and interventions in the health sector which has been sustained and improved upon, while new ones are being activated to ensure the well-being and welfare of Lagosians is in line with the Themes Plus agenda for a greater Lagos. As medical practitioners, we should be reminded that our core responsibility is to continue to uphold the ethics of this profession and strictly adhere to the best practices in the overall interest of the patients. We must come to terms with the fact that we have been chosen to render a special service to humanity. Therefore, I call on all healthcare providers to see this profession as an opportunity to make positive difference and actively participate in saving lives. Inasmuch as the government has the responsibility to continue to work to safeguard the health of residents, I also use this medium to charge corporate organizations, multilateral agencies, NGOs, and public-spirited individuals to also consolidate with the efforts of the government by coming up with various interventions in order to fast-track development and improve access to healthcare services. Your support in adopting public projects will further contribute to the universal health coverage objective of the government. Once again, I appreciate the unrelenting effort of the Association of Public Health Physicians of Nigeria, the Lagos State chapter, towards improving the health sector and add value. Let me assure you that as a government, we will not relent in our efforts in investing significantly in the healthcare system for the benefits of all. I thank you for your attention.
Thank you very much, Ma. Another round of applause for the representative of the First Lady. Thank you very much, Ma. 1 + 1 is equals to 2. No argument. Thank you, Ma. So let me invite, because we are moving on, to the keynote speech, but let me invite the person that will read the citation of the keynote speaker. And it's no other person than Dr. Elo. Yes, because we are doing this together. So I'm the co-MC, and this is the MC that will be introducing the keynote speaker. And I hand over the baton to you. You're welcome.
Thank you. The First Lady of Lagos State, Dr. Ibijoke Sanwo-Olu, ably represented by Mrs. Mustafa. The representative of the Deputy Governor's wife, the chairman of the occasion, Professor Akin Osipogun, the chairman of Aphpn Lagos chapter, Professor Kuinu. All permanent secretaries here present. Permit me to stand on existing protocol. I'm here to introduce our keynote speaker, and I am highly excited, elated, and privileged to do this. They say it takes a village to raise a child. The keynote speaker is part of my village. He's one of those who raised me. He's part of my village, so he is contributed in making me become who I am today. And so it's with so much pleasure that I'm doing this. Some fun facts about our keynote speaker. He was a member of the Man O' War when he was in school. And Prof, you were talking about picking up golf and squash when you retired. Have you started doing that? Another thing that I remember about him, that his favorite coach was Jose Mourinho of Chelsea. So for those of you who are Chelsea fans, Prof is also a Chelsea fan. So, sir, please, can you be upstanding while I read this very abridged citation of yours? Professor Adesegun Fatusi is a Nigerian professor of community medicine and public health, recognized for his strategic role in the fields of adolescent health and reproductive health, both nationally and internationally. He served previously as reproductive health advisor and with the United Nations Population Fund, UNFPA, the Nigeria office. He was also provost of the College of Health Sciences, Obafemi Awolowo University, Ile-Ife, director of international research at the Guttmacher Institute, New York, and the immediate past vice chancellor of the University of Medical Sciences, Ondo. He chairs Nigeria's National Adolescent Health Technical Working Group and serves on the Reproductive, Maternal, Newborn, Child, and Adolescent Health Technical Advisory Group for WHO African Regional Office. Please join me as I make welcome Professor Adesegun Fatusi, Professor of Community Medicine and Public Health.
Thank you very much. Hello. Good afternoon, everyone.
It's a great pleasure for me to be here today. And I want to thank the Lagos State Aphpn for the privilege. I think this is the largest gathering I've seen of public health physicians outside the national. And I must say it also has one of the longest protocol I have seen. Just before I set up, I want to be sure, am I supposed to press this or somebody, because this is behind me, so maybe is there somebody that can, sorry? You are in charge, sir. Are you in charge? Okay, fantastic. All right. Okay. So, the representative of the First Lady of Lagos State, the representative of the wife of the Deputy Governor of Lagos State, I will have said, permit me to abide with the protocol that has been laid. Let me quickly say that let me abide with that protocol, but yet, I think that there are things that I cannot skip in protocol. So, the special advisors, the panel secretary, let me use my friend, Dr. Dayo Lajide, as a point of contact. I've not seen her for decades. Dayo, I don't want sitting down there. I was just searching for her. Like, where is Dayo sitting down here? Of course, our chairman of the occasion and one of our very senior persons in our field, and our great mentor, Professor Konshibogun. The chairman of the Aphpn of Lagos State, my friend and sister, Professor Yetunde Kuyino, the chairman of the LOC, Dr. Morenike Alesoko, and I must especially acknowledge Dr. Lajo Dununga, who literally forced me to accept to be a speaker at this occasion. He was one of my resident ones and a great friend. You know, somebody used to say to me, a brother in need is a bloody nuisance. You can't escape him. Thank you very much, Laja, for the privilege to be here. The last time I was in Lagos, actually, really I come to Lagos all the time, was also for a conference. And I'm so glad that I'm here for another conference. Let me especially thank Professor Kufode, who was the chair of the LOC for the Nigerian Conference on Adolescent Health that I came for then, and Professor Lade Wright, who was the chairman of our scientific committee. What a wonderful time we had in Lagos. Lagos will always be Lagos. There's no other place like Lagos. Either you talk about traffic jam, or you talk about the beauty of the environment, or you talk about the achievement. Lagos is just Lagos. So there's no question about that. And a team of great professionals and organizers of events. I cannot but acknowledge I think the longest person I've known in this room is Bolaji Oshoba. No, somebody will sue me. Bolaji Obade. I intentionally said that. We were classmates in Ife those days. Bolaji, so good to see you. You will have noted that I have a long list of ladies listed out here. I thought this conference also talked about equity and equitability. So let me balance with at least two brothers. For the sake of balancing this, let me acknowledge Dr. Bayo Nojole, long-time colleague too, and Dr. Dunyo Dubanjo is here, the able Executive Secretary of Nigerian Academy of Science, all medical elders in the house, all colleagues, ladies and gentlemen. I'm particularly delighted to be here today because the theme for this event stirs my heart. And secondly, like I told a couple of friends, I have a number of friends and abros and egbons everywhere in Lagos. I hardly get in touch with Lagos crowd again when it comes to public health. You know, when you stay in the village, it's not every time I can come to Lagos, it's that you stay in some villages. And so it's such a great pleasure to connect with a lot of you. And thank you for all the great things all the great works you've been doing. I also want to say I'm particularly very excited reading through the program material. Don't worry. Oh, I need it. I don't need it. Please give it to them. They have. All right. Okay. While she's setting that up. So, I'm particularly excited to be here today because I also noted that you are honoring 3 people with Lifetime Award, Professor Muriel Yediron, Professor Salami, and Professor Umekon. All the three of them were my teachers when I did MPH in Lagos in 1991. So what a great day to be here with all of you. And thank you for doing them that honor. Today, I'm talking on the theme, the global health under threat, sustainable financing and workforce capacity for equitable care delivery in Global South. There are 4 things I would like to cover in this presentation. Number 1, I'll start off by talking about the global health at crossroads. What are the emerging and escalating threats? Secondly, I'll touch on the issue of global health shifts, the realities for health in the Global South. Thirdly, I would dovetail this to what the national context is by talking about from global to local. All right, it's working. All right, I talk from global to local, Nigeria and the new global challenge, and I will end by talking about where our response mechanism can become far more strengthened. Just to illustrate what that means in one dimension. Let me illustrate that in one dimension. I talked to you about 7 threats, but the threats are not separate, independent threats. The reality is that they are interspersed and they are interconnected, and they reinforce the effect of each other. And I will illustrate that with climate change. When you take a look at this picture and you look at the vulnerable factors, you find things like geographical factors, you find things like demographic factors, you find things like biological factors, socio-political factors, socio-geographical factors. Those factors are not just operating independently, but across all these threats, they are strengthening the threats and increasing their impact. And the outcome they produce, or the risk they engender, also on its own reinforce what will happen. And I just pick on one, which I'm going to elaborate on. When we have the whole issue about climate change, one of the things that's happening is that the ecosystem around Earth and the vector population, the vector distribution are changing very fast. And that in itself will also result in a couple of things in terms of health outcome. Begin to have more waterborne diseases, more zoonosis, more vector-borne diseases. In other words, we are beginning to see more outcomes, more epidemics that are going to happen. On the other hand, take a look at the far right. We look at the health system capacity that should be responding. The health system is getting weakened by the same factor that are also producing the challenges that the health sector need to respond to. And we need to begin to then think in a more organic, in a more holistic way as we think about how do we change the narrative in year 2025 and beyond. Just to go further in that illustration, I jump to one slide. As you look at this picture, one of the things that strikes you is that the time between pandemics are getting shorter and shorter. And that reality is something we must live with. I wish I have a lot more time. No, but take a look at this. If you look at WHO report and talking about what some of the factors we need to begin to respond to, they talk about disease X. Disease X or pathogen X, depending on what you are reading. It's talking about an unknown disease or unknown pathogen, but that there is certainty that is going to occur. The question is not will it, the question is when will it occur. And what studies have shown is that we are having a 3-fold increase in the risk of diseases within the next decade. And the possibility that we experience a pandemic like we saw with COVID-19 has become so high. Just to look at the last sentence there, that the probability of experiencing it in one lifetime currently is about 38%, and that may double in the next decade. Okay. So, like I said, we are having increased intensity in the threats, and we are having a weakening in the capacity to respond. One of the core capacity to respond has to do with the funding that we have and the capacity in terms of funding. And like we all know, AIDS is getting caught at a very dramatic rate, and perhaps one of the most popular people in the world when it comes to what's happening in terms of AIDS is President Trump. And it's not just about what he's doing in terms of withdrawing money or dismantling USAID, but what he has also done to the global architecture. About 500 million was withdrawn from WHO. And so WHO capacity to respond is threatened. And all of that together is bringing us to a new dynamics that we must be conscious of. Let's talk a little bit more about what this means in terms of the AIDS per se. All right. One of the things you noticed in my last slide, which I didn't call your attention to, is that the decrease we are seeing in AIDS is not just about USAID. It's all across the world of global north. But the person we keep on shouting is Trump. And the people we keep on talking about is America. For good reasons. Take a look at this. You find that if you look at the proportion of AIDS that come from America, it's very, very significant globally. And so when America coughs, as it said, or it sneezes, it doesn't even need to cough. People start catching cold because of that huge proportion. And I'm going to come back to that issue as we go on. And as you see generally, AIDS has been reducing for the last number of years. But the last 3, 4, 5 years, really, the AIDS going to health has actually been decreasing. What happened was we didn't notice because nobody shouted about it until Trump did something that woke all of us from our sleep. Okay, so, but it's not all bad news. If you've been following the news, some nice, interesting things are beginning to happen. Few funders had maintained their fund, and some had even increased. According to the Financing Global Health 2025, published by the Institute of Health Metrics of the University of Washington, you find countries like Australia, they have increased their aid by 2.6. Japan had increased by 2.2. Global Fund just a few months ago celebrated its ability to raise more than $1 billion. Interestingly, America was one of the major donors to that in this September. Even though everybody thinks that, oh, Trump had cut off. No. And I'm going to come back to that. Gates and others have launched new funds, and some countries are redirecting funds to partner countries that they think need more attention. And so it is not all bad news. There is still aid around. There is less aid, but there is aid around. So what's the outlook for the future of AIDS? Clearly, there is a situation where the global availability of AIDS had been compromised to a reasonable extent. For sure, the 5 years of Trump, you can be sure AIDS will be low. And so if nothing else, you will see about $10 billion cut off because of Trump's agenda. But if you take a look too, the OECD published a policy brief earlier in the year. And they said this was about June. And they said, I'll just read that quotation. The OECD projects a 9 to 17% drop in ODA. That's official development assistance in 2025. This comes on top of a 9% drop in 2024. And the next sentence is the more interesting one. The outlook beyond 2025 remains highly uncertain. So even though some funders had tried to respond to close that gap, the reality is the future is more uncertain than ever before. So, is that surprising? No, it shouldn't be surprising. We live in an age of VUCA, volatility, uncertainty, complexity, and ambiguity. And in a world like that, global health cannot but be threatened. It is just up to us to wake up to that reality and to grapple with it and to think how we can make a difference. Let's dovetail to the global south and see what happens. As you take a look at the next slide, you look at what this was produced by the Lancet Commission on investing in health. And one of the things it does was to look at premature death and the potential of being able to elongate life, double life by 2050. So they're looking here at the probability of premature death. And when you take a look, oh, sorry, this is, right? Sorry about this. If you take a look, you find that as you look at all the continents, Africa has the second highest population, but it has the highest risk of global death. and the lowest economic income per capita. Even when you are talking about inequity, it's not about north or south alone. It's also even between the global south. There are a lot of inequity. And we in Africa are more disadvantaged than any other group. If you take a look at that slide, I hope you can see it. You find that for America, the rate of premature death is only 22%, whereas in Africa, it's about 50%. The amount of money year 9 for America is 74,500. For Africa, it's only 4,000. And so clearly, inequity is a big challenge. But like I said, even between different areas of global south, you see that same kind of pattern. If you pick a country like India GNI is about $9,000, but Africa is only about half of that. If you pick the issue of risk of dying prematurely before age 70, in Africa it is 50%, in India it's 35%. So the inequity issue is an issue that has to be seen more broadly and than just north-south divide. So let's talk about what would this then mean when you think about aid and the money we spend. So what have we been spending the aid for? Or what are the aids actually been doing? When you take a look at this, one of the things that is clear is that the countries that provide aid focus more on diseases that can become a risk to them, not a risk that is your problem. Let me repeat that. That when they give aids, it is because of the diseases that can become their problem, not diseases that are your problem. And so they invest more in diseases like HIV, tuberculosis, things that can spread to them. Things like malaria that is your own primary problem doesn't get as much until recent years. And so even AIDS has its own dynamics, so to say. And so you see it has been growing up. And when you look at the years when HIV became a big issue, you find that that is going up more. And so you must understand how AIDS play out in the health sector. All right. When you think about that in a different way, and say, look, Africa, the global south has a lot more challenges. They are dying more. But how much are they spending? And how will this be impacted by the amount of costs in it? You find that the total spending per person in most of Africa is just between $10 and less than $500. Whereas in America, it's about $2,500 to $15,000. On the average, the spending in global north is about 299 times the spending in developing countries. I'll say that again. On the average, the spending per person in the global north is about 299 times the spending on the spending per person in developing countries. So how do we expect to have the same outcome? But within that dynamic is also the fact that they are not training enough health workers and they are stealing your own health workers, despite all those dynamics. And those are questions that we must interrogate at different levels. So we have that challenge about a health problem that is increasing. We don't even have enough money to spend, and we are not spending enough money. As we look at that picture of global AIDS and what it means, therefore, you find that there's going to be a 21% decline in development assistance globally in the next 1 year. And out of that, the decline is going to be greatest in Africa. Africa is going to have 25% as against 21%. Oh, sorry, I didn't move that. As against 21% that you see generally. And about 67% estimated reduction in funding will be experienced, both from the US government and from other government. So, what is the fate of Africa as we move on? Africa faces a very challenging task that is not just sectoral, but almost existential in nature. Africa has a number of factors driving its health sector crisis. Number one, it has a fragile health system. Number two, the decline in AIDS is affecting Africa disproportionately. Number three, most of the programs, this is why I wanted somebody to decide that kind. Oh my God. Where did I leave you guys? Oh, all right. All right. I apologize. Thank you for pointing that to me. I was just going to keep on giving my lecture on. All right. So Africa has a fragile health system. Part of the problem is that Africa has inadequate health workforce, about half the ratio the WHO had recommended, and yet Africa is getting hemorrhage daily in terms of health workers by the countries that have more. And most of the backbone of the program in Africa to respond to emergencies and epidemics, they are almost all funded by global north. Africa also has a challenge of servicing debt. In fact, the amount of money Africa used to service its debt is more than all the external funds that Africa gets in return. So even if Africa does not get anything and it gets debt forgiveness, it's far better than otherwise because it's spending so much money to service debt. Of course, we have not been budgeting for aid appropriately. Only about 3 countries had made 15%. So this is not, and here I'm quoting African CDC. This is not just a sectoral crisis. It is an essential threat to Africa's political, social, and economic resilience and global stability. So in other words, Africa needs more money, right? And Africa has been getting some money. So when this aid happens, how is Africa going to be impacted? This shows the global picture about where money has been going globally between 2014 and 2018. That's the last data WHO has. I circle Nigeria. Nigeria is one of the countries that has received the largest amount of money globally. In fact, Nigeria stands as the country that has received, the singular country that has received the largest aid globally, followed by Ethiopia. And Africa has much more countries in this equation than other countries. So when the aid for health gets cost, Africa is naturally going to be the one worst hit. And it's going to be worse for some countries. This is the picture about how much money Africa is putting in its own health budget and how much it gets from other people. For countries like South Sudan and Zimbabwe, almost 60% of the entire health spending come from donors. About 60% come from donors. This is about the 20 countries in Africa that has the highest number of donors' contribution. From Guinea, that has about 22%, to South Sudan, that has about 60%. And so when it gets caught, these countries naturally will be part of the worst for it. And we can look at that picture in a slightly different way. In other words, what will happen to countries in Africa would differ largely by 2 things. Number one, what proportion of their health budget come from AIDS and what kind of response they put in place. And I choose 3 countries to represent 3 scenarios. If you look at Botswana, that's the popular line. Botswana has less than 5% of money coming from AIDS. Kenya has probably close to 20%. And then you have Zimbabwe that has almost about 60%. And so when we talk about the impact of AIDS, global south, there's no global south. Each country will find itself at its own problem and struggle to survive as best as it can, based on what portion of his money come from AIDS. But as a whole, there's a big question that has come. If Africa so much depends this is a question somebody asked. That one of the questions, one of the lessons that had come from this issue is that the retreat of the US from global aid has left more than a funding gap. It has exposed the weakness of a system that leaned too heavily on a handful of donors. So when any of them acts or reacts, then the whole global system is in shambles. And that, again, is a question that needs to change. I'm going to move a bit faster now. This is about what's going to happen to us. Let's move on to, so what will be the impact of this AIDS on a global level? Just to take one example, HIV, that according to UNAIDS, the projection says that with reduction in AIDS, between 2025 and 2029, we'll have 6.6 million new cases of HIV. All right. Say that I have 15 minutes more, so that's more than enough. If I ever tell me I have 5 minutes more, I'll stop at 5 minutes. No. All right. But you know that there's a second side to AIDS beyond money. And there's a dark side to the story of AIDS that we don't often talk here. One of the dark sides is this. If you take a look at this picture, sorry, something keep on going wrong with this. I keep on pressing something wrong. Yes. All right. Thank you. No, go back. No. Go back to that slide. To just the, yeah, that's one. One of the things you see, as you see AIDS going down, what happens is that the money that governments put in AIDS, put in their own economy, become less. And I'm sure that those who work in state and national system know that. There are many people who are in charge of programs, and they go to the governor and say, oh no, but UNS is giving you money. Oh, why do you want more money from me? After all, you are running malaria program, and Global Fund is giving you money. And so one of the things that AIDS has done is that it has literally discouraged government from putting money into some of its programs. So as AIDS has been going up, government kept on reneging on their responsibility. They've seen somebody who's helping them to carry that. That's one of the dark side of AIDS. The other dark side of AIDS, as you can see, is that if you look at those line plots, you find that the places where there's the highest donor coming in is where the problem about things like HIV is more. So there's also inequity, even in the aid that is given. It's based on how they see the problem being able to affect them. Otherwise, you get very little aid from them. There are other dark sides to AIDS. Next slide. Next slide. Are you okay? This came from America, the report released by President Trump's team recently, talking about America. I know they made a statement that, as far as I'm concerned, cannot be controverted. They talk about the fact that AIDS from US has done a lot of good. But there are two major elements in that are problematic. Number one, those AIDS had caused dependence, donor dependence, like we have talked. And there's a lot of inefficiency in the use of those AIDS. We know there's a lot of corruption that goes on within the global AIDS and global fund agenda. And we also know that, so it's not all the money they say that come to country that come to country. There's a whole lot of things that happen. And even at country level, there are a whole lot of things that happen. So the AIDS is really not achieving as much as it should achieve. Not all that they said they spent happen to be spent. At any rate, if you get money from America, you have to buy American products. Either it is cost effective or it's not cost effective. So those are all parts of the game. Next slide. This is a report that came from UNDP. And I'd like to read to you the sentence in red. He said, in these disruptive and uncertain times, the proliferation and fragmentation of the AIDS system continues to jeopardize the effectiveness, quality, and impact of development cooperation. So you have all different lines of activities, and they are all causing conflict within the AIDS system. All right, let's go on and talk about Nigeria as I begin to wind down next few minutes. Let's talk about Nigeria. All right, so from global to local, Nigeria and the new global health challenges. Next slide. I don't need to talk to you about Nigerian health system. I don't need to talk to you about Nigerian health indicators. I don't need to talk to you about what the profiles are because we are all in that system. Just to remind you that in a summary sentence that I find very interesting, World Bank says Nigeria ranks among the bottom 5 or 10 countries globally on most key health indicators. Either you talk about maternal mortality or you talk about just mention it. We rank in that dimension. So what's the problem? Next slide. Jump down because of time. All right. This talks about how much Nigeria has been getting over time. And one clear picture is that Nigeria has been getting more and more money over time. Go to the next slide. So what have you done with the money, or who has been giving us the money? Next slide. So this is the landscape of donor in Nigeria between the last couple of years. Again, WHO's latest data is about 2018. The biggest circle is US government. So when you take that circle out, there's a void. As of July this year, Nigeria has 52.1% deficit in the funding for contraceptives. Because USAID, for example, which is one of the biggest donors, had withdrawn. Next slide. So how will this likely impact Nigeria, this reduction in AIDS, impact Nigeria going forward? Oh, that's the right. So how will this likely impact Nigeria? I was at another program speaking a couple of weeks back, and somebody made a statement that the proportion of development assistance to Nigerian spending is low. And I said, yes, it's low. It's low, but it's very strategic. Why? All the money that comes from external donors to Nigerian spending is only about 7%. But all the money that comes from government is only about 14.5%. So donor money is low, but it's strategic. Because most of the spending that comes to Nigeria comes from out of pocket. And that's why the whole issue about how do we begin to make people have access to insurance becomes critical. Next slide. What have we been doing with our money? Again, just like the picture you've had before. TB, HIV are the biggest money. But where do we need more money? Strengthen the health system is where more money needs to go. And that's one of the least places where money has come. Because no matter what you do in HIV, when our health system is weak, it doesn't have the carrying capacity to sustain things over a time. And that is one of the challenges that we see in HIV, that you see with AIDS. Next slide. We've gotten, for example, USAID published that we've got 580 million in 2023. 330 million went to HIV/AIDS. How much went to health strengthening? Very, very little. And so that's one of the challenges that we'll see. The biggest gap that we need to address will be with things like HIV/AIDS, where much more money has been going. Let me begin to end by talking about how do we reimagine the future from perplexity to publicity. One of the key questions that we need to answer is this. Will African government allow the cycle of dependency to continue? Or will this be an opportunity to reassert our sovereignty over our own health system? To determine what is most important to us and determine how we need to run it. Let's go to the next slide. The simplistic thinking when it comes to AIDS issues, they are cutting it, so let's increase, let's do for more money. That's very simplistic. That's not the answer to the question. Of course, we can increase the funding, mobilize domestic, we can reduce the wastage, but there's something more fundamental that we need to do in the age that we are in. Next slide. The question people have been asking is, okay, money is less, how can we maintain the service? That question is not fundamental. Like this quotation says, the journey from donor dependency to domestic sustainability is not just about finding new money. It's about reimagining how our systems are structured, how they are delivered, and how they are governed. And so what's the core question we need to ask ourselves? The key question and the real issue, therefore, is this. Go on. How can we design or redesign our health system to function optimally, powered primarily, not totally, by domestic sources? Of course, we all know about all that the federal government is trying to do, the National Health Sector Renewal Investment Initiative, which has some great promises. But I have like 5 or 7 minutes to go. Let's go to the next slide. One of the things that excites me is that Nigeria is now publishing State of the Art Nation. I don't know how many of us have read it. When you read that report, one of the things that is clear is that Nigerians says they don't believe anything's happening in the health sector. In fact, a high proportion of Nigerians think that the health sector is not performing well, and they don't have enough confidence in it. But the good thing is that at least we are assessing ourselves. At least some things have been done. And some of them have high promises, but we are still in the very early phases of seeing what Nigeria is trying to do. So there's so much that remains to be done or accomplished. But if we keep on the pathway of reform, we are most likely going to get to where we desire. Next slide. I'm going to end with just highlighting a few key steps that I think we need to do moving forward. Number one is about health system thinking and health system approach. One of the things that is missing in Nigerian health sector is health system thinking. I used to say, when I was a resident doctor and our salary was increased, I used to tell my colleagues, that doesn't make sense. You don't increase doctors' money and you leave nurses' money not to increase. The nurses must be idiots, not to protest. The lab people must. And so when you act that way, you are not helping the system, you are not helping your colleagues. It's not helping colleagues. It's about the fact that you are not thinking systematically. You are not thinking, because to think in a health system approach means that you must think about everybody together. In fact, taking doctors out of the whole health sector and creating MSS does not reflect systematic thinking or system thinking. And so as we go forward, we must think about the system, because what happens in one part of the system will affect others. That's why it's a system. And the other thing to do is that we cannot pay attention to any of these system building blocks without paying attention to the others. You build a health facility, you keep it, you don't get doctors. Is it going to be run by mouse or by chicken or AI or something? And so we must begin to move to a realm where you must think more health system thinking and more health system approach. We must look at the health system as the place to truly invest to make it stronger. Next slide. Number 2, we must improve domestic funding. No, move to the next slide. We must improve domestic funding. And there are 3 things we need to do. Number 1, in terms of health allocation, we need to increase our health allocation, of course, with a high level of accountability. Number 2, we need to improve financing mechanism to bring the gap. And there are many other things we can do. Tax, those of us who are taxable, those who travel, on drinks, on tobacco, and all of that. To mobilize more money. We must be more public-private partnership to mobilize more money into the system. And we must also expand the network for people to have health insurance so that many more people can get there. And number 3, we must also harness a blended approach, finance mechanism, that's going to reduce our dependency on logistics from other places so that we can have money, we can begin to produce vaccines and other things, and others can buy from us. That way we can make a lot more money than just spending and spending. These 3 approaches are approaches that can help us to begin to get better in terms of what we need to do in finance. Number 4, we must effectively and optimally manage and use aids. A couple of years ago, I was doing a consultancy for a group looking at what is called the aid effectiveness. And one of the findings is that Nigeria has a more poorer outcome when it comes to how to manage partners than places like Rwanda. In Rwanda, you just don't do anything. Thank God for Lagos. Lagos is one state everybody knows that, look, if you want to come to Lagos, you must sit tight. But in many other places, donors are just running the show and nobody's talking. You must find a mechanism and ensure that every money you bring is to support our system, not to destroy our system. That must be something we must do. Number 4, you must prioritize prevention. You must prioritize primary care. And we must prioritize evidence-based approach. In this report by Lancet Commission, they've shown that there are 15 conditions which, if we invest in, we can reduce premature mortality by 50%. I don't have enough time to be reading there, but infectious and maternal health conditions are there, which we are working on. Malaria, neonatal lower respiratory condition, diarrhea. But there's also SCD and injuries where we have not focused attention. And so we need to focus a lot more attention around the SCDs and injuries if we must reduce premature mortality. Number 5, we must address the workforce migration. It's not about policy. Policy is good, but there's much more. If you are kidnapping doctors, you are kidnapping nurses, even if you offer them $1,000 a day, people value their life more than the money. So we need to have an environment that we address both the push factors and the pull factors. Number 6, again, because of time, I can't spend too much time. Number 6, if you need to expand the production of human resources, just on Monday, I was giving a lecture in University of Ibadan to a foundation around some issue like this. So I don't have the luxury of time here. But 5 things I will let you know. Number 1, we need to strengthen the foundation for science education. It is not the university that you start strengthening science education. No. If you get poor input into the university, you're going to get poor output no matter what happens. So we need to go back to primary school and secondary school and strengthen science education, particularly in our public schools. Number 2, we must expand this training infrastructure across the country. Federal government has said, go and increase number of entrance to medical school. I'm sure Luke didn't respond. If I didn't respond, because they're like, what are we supposed to do? We have limited infrastructure, you want us to expand, you have not expanded us. Government has started responding to that, but that needs to be done more consistently and universally across the country. Number three, you must think about innovative technology to improve our teaching and to strengthen the capacity of teachers. Number four, we must look at how do we retain teachers. At the lecture on Monday, I showed a title, something that Sponge wrote, and said salary of teachers, of university teachers, had been stagnated for 15 years. That is not true. The truth is that the salary of university professor had gone down to an eighth of the value in 15 years. In 2009, the average value of the professor's salary was $4,000 per month because the rate then was 1 to 120. That had not changed. Now the average take-home of the best paid professor is less than $400. And so how do you want to get young people into that system? Someone say, wow, oh, that's how much we earn, by the way. They cannot even buy you a ticket to travel. So if you want to retain teachers, then you must think about how do you ensure that you pay them something that will make them stay. Otherwise, only people can't find job who come to medical, who come to teach. We've gotten to a level now where you do postgraduate exam in the laboratories and you hardly see candidates to come. And yet we are expanding schools. But like I said at another lecture, I think some people have a manufacturing unit where they manufacture lecturers. Because School of Nursing is expanding every angle. There are 65 new School of Nurses that they have approved in principle to take students over the last 2 years. Whereas from 1970s to 2 years ago, there were only 43 universities. So you have more than approved, more than all that existed. In the last couple of years, in the last 2 years, the government has established how many more universities? About 23 universities. Where are the teachers? Anyway, we must think about how do we produce the human resources. And then we must ensure regulation. We must keep standard. Number 7, which is my last one, is that we must think about this system. And we must think about a people-oriented system that is community-rooted and accountability-based. There is no sustainability where there are no people. When the community owns the facilities, forget about it. Government doesn't need to do anything. Because if you come to destroy what belongs to them, they will destroy you first because the seat has belonged to them. But as far as the seat has belonged to government, anybody can do anything. When I was working in Delta State with UNFPA, I remember an incident that happened where I got to the local government and I said, where is the chairman? They said, oh, he ran away. I said, why? He said, one woman died and they took the woman to her house, to his house, that he must bury the woman. That because he was the one that did not provide the facility, so you must be the one. And they insisted. And this was one of those Ijo areas. So the man took his and just ran away from the community. And that's what we need. Once the community recognizes their rights and they embrace their rights, they will protect the assets. They will make sure it works because they see it as their own. And that will promote ownership, locally, accountability, and sustainability. I would like to end with perhaps a few words. At a meeting of African Minister of Health a couple of months ago, the WHO Director General asked this question. He said, but in this crisis, no, he made this statement, excuse me. He said, but in this crisis, the global aid crisis, he said, lies an opportunity to shake off the yoke of aid dependency and embrace a new era of sovereignty, self-reliance, and solidarity. Let me offer a few conclusions and thoughts as I begin to close in another 1 minute or two. Next slide. Many of us heard about this. Nigerian lawmakers approved 200 million to offset shortfall from USAID. Where has that money gone into? Who have they supported? Have you asked questions? Or is this just propaganda? But I will leave that question there because I don't have the answer. Next slide. But something I read this week that really thrilled my heart. A quotation from Mr. Bimbola Saludin, SSG Lagos State. It's a long quotation, but permit me to read. I read this in Guardian. It says, earlier this year, the stop work order issued by the United States government brought significant disruption to community-based HIV services across the country. And Lagos was not exempted. Testing stalled, counseling paused, home-based follow-up was interrupted, psychosocial support systems were strained. Many people lost contact with services they relied on for life, stability, and dignity. These disruptions were not abstract. They were personal. They were real. They were felt in homes, in communities, and especially in the hearts of people living with HIV. But Lagos did not stop working. We did not stop. That really excited me. US may have said stop work order, but the state has a responsibility to continue working for its people. Next slide. And this is going to be my second to last slide. That sentence went on to say this. He said, we are firm in our resolve that donor dependence cannot and shall not be the foundation for our future. Therefore, we are choosing to build and have started building a stateless sustainable system. I hope this is not newspaper. I hope this is not propaganda. I hope this is real. I read in the newspaper, I don't live in Lagos. But I hope this is real. And I pray this is real. Because this is the spirit we need at a moment like this. I want to conclude by saying to you, friends, that reimagining a health system that can enable us overcome existing challenges and meet the demands of the future and meet unprecedented global changes and transitions in a sustainable way is doable, and it must be done. Changing our narrative from perplexity to publicities, it is task for today and not for tomorrow. I want to thank you very much for your attention.
Thank you so much, sir. I'm not surprised at all. I'm not at all surprised. Thank you so much for the performance. Like, there's so much to learn. He took us through a whole lot, you know. We know what's going on, the progressive decline in foreign aids, our fragile health system, and all of that. And the fact that our emergency preparedness and response in Africa is largely donor funded. He mentioned that Nigeria is a singular country that has received the largest aid, and so inevitably the most worst hit. Comparing certain countries from Botswana receiving less than 5% foreign aid to Zimbabwe with over 60% funding from the US. Of course, again, disproportionate funding of certain services like TB and HIV to the exclusion of others, and most importantly, health system strengthening. Talked about what we can do and asked a very, very important question. Will African governments allow the cycle of dependency to continue? Or are we willing to move from perplexity to possibility, to increase funding, reduce wastage, and reimagine how systems are structured, delivered, and governed? He said it's not just about looking for more funding, but to harness blended financing to address infrastructure and supply chain gaps. And then the way forward, to focus on 15 priority conditions which have the potential to cause a 50% reduction in mortality, in addition to non-communicable diseases. To also address push and pull factors, he talked about insecurity, kidnapping of doctors, and no matter how much remuneration healthcare workers are getting, these push factors, if not addressed, would still be a major cog in the wheel of progress. To expand the production of human resources for health and strengthen science at the basic level, not just because he talked about, you know, the garbage in, garbage out is what you put in there that you eventually get out. The use of innovative technology and strengthening health professional education capital or capacity. Then, to recruit more teachers, improve remunerations and motivation, as well as appropriate regulation and quality assurance mechanisms, amongst so many other things he said. Thank you so much. I hope our patrons got all of these things, and they'll be adequately reflected in our communique. We move on to the next item on the agenda, which is the presentation of lifetime awards to certain individuals who have been considered worthy of such. And to do that, pardon me, So to present the Lifetime Awards, we'll call on the representative of the First Lady, Mrs. Mustafa, right. Please, a round of applause for her as we welcome her.
Thank you.
So, the first recipient of this Lifetime Award is Dr. Muhammad Y.I. Salami. Dr. Muhammad Salami was born on the 16th of February 1940. He's a distinguished physician, public health expert, and academic leader with over 5 decades of service in medicine, public health administration, and medical education. A graduate of the University of Lagos in 1967 and an MPH from Johns Hopkins University in 1969. He specialized in population dynamics, family planning, and comprehensive health planning. He is a foundation fellow of the West African College of Physicians and a fellow of the National Postgraduate Medical College of Nigeria. Throughout his career, Dr. Salami has held pivotal roles in Nigeria's health sector, including medical officer in charge at the Infectious Diseases Hospital Yaba, senior consultant and medical officer of health at Lagos City Council and mainland local government, chief consultant across multiple Lagos state local governments such as Ikeja, Lagos Island, Lagos Mainland, Mushi, and Ikorodu. Director of Medical Administration and Training at the Lagos State Ministry of Health, and Permanent Secretary to the Lagos State Hospital Management Board. He also served as Associate Lecturer in Community Health at the College of Medicine, University of Lagos, for over 3 decades, and his research contribution span child health, epidemiology of infectious diseases, environmental health, and solid waste management, with publications in national and international journals. He has also played a central role in advancing public health education, serving as chairman and secretary of the Faculty of Public Health at the National Postgraduate Medical College of Nigeria, project director for the Johns Hopkins sponsored Aphpn program, and examiner for both the West African College of Physicians and the National Postgraduate Medical College. Dr. Salami has delivered numerous public lectures, including the Faculty Day Lecture of the Faculty of Public Health in 2007, and has participated in countless seminars and workshops shaping health policy and local government administration. His contributions have been recognized nationally with the Officer of the Order of the Niger, OON. This was in 2003, alongside awards from the University of Lagos Alumni Association in 1985 and Distinguished Fellow of National Postgraduate Medical College of Nigeria.
So right now we invite the First Lady to help us present, the award to Dr. Salami. Thank you.
Congratulations, sir. This is presented to you. Presented to you by the Aphpn for all your dedication, your service to community and to the humanity at large. Congratulations.
Thank you very much.
Thank you very much, Ma. For those of us that had our MPH in Unilag, I'm sure you remember Dr. Salami, waste, environmental health, absolutely. And then he was the one that brought in this kangaroo dinosaur bean. God bless you, thank you. Dinosaur bean, so I can't forget. So thank you very much, sir.
So I'll go on to read the citations of the other two awardees before we present them simultaneously. So our next recipient is Professor Mrs. D.A. Ogumekon. Professor Dorothy Adebukola Ogumekon was born on the 7th of January 1937 to Bishop and Mrs. I.G.A. Jadesimi. Bishop Jadesimi was a distinguished Anglican bishop. She attended St. Anne's School, Ibadan, the University of St. Andrews, Scotland for undergraduate medical degrees, and the Dundee University for her postgraduate medical degrees. She was awarded fellowships of the West African, National, and United Kingdom postgraduate medical colleges with qualifications of MBCHB in 1963 from St. Andrews, DPH 1968 from Dundee, MD in 1975 from Dundee, FNCPH from Nigeria, and FWACP, the West African College, as well as FFPHM from the United Kingdom. In addition to lecturing, she undertook research in BCG for the prevention of tuberculosis in children, neonatal tetanus, rubella, measles, and the sensitization of children to opportunistic mycobacteria. This research resulted in publications in many local and international journals. Professor Ogumekon ran a weekly clinic for immunization of children against the common childhood diseases. Her impact on her students in the principles of epidemiology, epidemiology of communicable diseases, and immunization resulted in a number of them pursuing these fields. Professor Ogumekon supervised projects for undergraduate medical students and postgraduate students in the MPH program, as well as resident doctors preparing for the FMCPH examination, and accompanied the final year students on rural health postings outside Lagos. Professor Dorothy Ogumekon retired as professor and head of department after 35 years of service at the College of Medicine, University of Lagos. So she's represented here by her son, Mr. Dolapo Ogumeko. Yes. Please, can we have Professor Roberts here, please? Thank you so much, ma'am. She'll be representing Professor Muriel Ayodeji Oyediro. Professor Oyediro is the third recipient of this award. Professor Muriel Oyediro was born on April 23, 1941 in Lagos to the late Professor and Mrs. Oladele Ajose. The late Professor Ajose was born a prince of the royal house of Oba Ologunkutere of Lagos in 1907. He had the rare distinction of being the first Black African and Nigerian professor south of the Sahara when he was appointed to the chair of preventive and social medicine at the University of Ibadan, as well as being the founding vice chancellor of the University of Ife, now called Obafemi Awolowo University. Mrs. Beatrice Ajose Nee Roberts grew up in Glasgow, although she was actually born in America in 1910. After meeting Oladele Ajose when he was a medical student at Glasgow University, they married in 1933. It was at Mrs. Ajose's insistence that they returned to Nigeria in 1936, where Dr. Ajose took up his first appointment as Assistant Medical Officer of Health to the late Dr. I.O. Oluwole. As professor and head of the Department of Preventive and Social Medicine at the University of Ibadan, Professor Ajose was the first public health teacher to establish the principle that public health teaching should take place outside the walls of the university and that the community should be involved throughout the decision-making process of establishing their health needs. Having been born into this illustrious medical family, it was natural for Professor Oyediro to follow in her father's footsteps. She attended the then St. Mary's Hospital Medical School of the University of London from 1959 to 1965, now part of the Imperial College of the University of London. At the end of her university training, she had obtained both the LRCP, MRCS, licentiate medical qualification, and her MBBS degree. She attended the then Johns Hopkins University, now the Johns Hopkins and Bloomberg University, where she obtained her master's degree in public health in 1969. She was later awarded the fellowships of the West African College of Physicians and the National Postgraduate Medical College of Nigeria in the faculties of public health in 1978 and 1982, respectively. Professor Oyediro was appointed the acting head of the Department of Community Health in 1984 to 1985 and head from 1989 to 1990.
ngingakwazi yini kodwa sengiyathemba manje ngiyakhuleka emathandabuzweni ngoba ukuzethemba yakhulula umoya ngoba ukuzethemba emene bathenga biko ngoba ukuzethemba yakhulula umoya ngoba ukuzethemba emene bathenga biko nokwamukela ngoba ukhululeka kumuso thina ngoba ukhululeka kumuso thina Imicabango yami yangikhathaza kodwa manje ngiyazikhulula kuyo ngifuna ukukhaphela ngaphandle kokwesaba ngiphumulele kudezelweni
So yes, so yesterday as part of the plenary sessions, we had a discussion on that essentially looked at the role of public health physicians in medical practice. And this was a very burning issue that bothers everybody that looks around about the progress of the profession and critically think about what the next steps are and what does the future hold for our cherished specialty. We all know that most times when adverts come out from secondary hospitals, I mean the general hospitals and the federal medical centers, you find that most times they do not have placement for community physicians. They do not recruit community physicians. The same thing happens in the Health Service Commission. And yesterday on that panel of discussants, we had the Permanent Secretary of Lagos State Health Service Commission. We also had a public health physician who is the medical director at one of the hospitals in Lagos State. And we also had the chairman of the Health Service Commission seated. And we were looking at what are the options, what do they think are the limitations, and in terms of training, what are the skills that are needed for us to be, in quotes, employable by them. Because you find out that in most cases, when you finish your fellowship program, if you don't go into academia, your choices appear to be limited. And we do not feel that should be the case. We feel that as a public health physician, you can function effectively in a general hospital because you have the needed skills and the capacity and capability to work in those places. And that was what influenced that discussion, that topic, as a panel of discussants yesterday. And at the end of the session yesterday, for those who were present, there was a general agreement that an average public health physician trained is equipped with all the soft skills and the capabilities to support healthcare management in secondary healthcare facilities. If public health physicians has the wherewithal, the knowledge of epidemiology, the knowledge of management, the knowledge of community entry, and is the only one that is capable of providing a link between the facility and the community where it's situated. And that was an agreement by all. And we're going to be following up that with the Permanent Secretary of the Health Service Commission of Lagos State and also the Chairman of the Health Service Commission of Lagos State. The Chairman of the Health Service Commission of Lagos State also concluded that there's been a lot of ongoing reforms in the system and that things have actually changed from what it used to be, and that at present now there are a couple of public health physicians that have taken up roles either as medical directors or they are placed in significant roles in the organization. So it's not worthy to say that that session was a success and again was a reassurance to everybody present yesterday that public health physicians have a very significant role to play in secondary health care delivery services. It's also very important to note that before that session started, we had our very own Professor Oshibogun made a presentation. And one of the key points to take away from his presentation yesterday was the need for us to also know ourselves. You must know yourselves, and once you know who you are able to actually let anybody know that these are the skills and the soft skills that you have, and these are the services that you can offer. So in summary, just a reassurance that there's a place for public health practice in secondary health care services, and we will be taking that conclusion up with the Health Service Commission in Lagos State, which was represented by the Permanent Secretary and the Chairman of the Commission. Thank you very much.
So we'll be going for lunch now. However, we're going to maintain the same order we did for tea break. Kindly remain seated. Kindly remain seated until an usher comes to lead you to the lunch area. After lunch, we'll come back for the reading of the communique. So please just kindly remain seated until your table gets ushered for lunch.
Hello. A pleasant afternoon to us all. I'm sure we're all enjoying our lunch. I'm Dr. Rike Ogunyemi. Please kindly indulge me while you are enjoying your lunch. I'll be presenting the communique of our conference. This is a very crucial moment because all that we have said, we have documented. Perchance we have omitted something or we have documented things that are not true. This will be the opportunity to kindly help us correct these errors before the communique is released into public. Thank you very much. So, the communique issued at the end of the 7th biannual scientific conference of the Association of Public Health Physicians, Lagos chapter, held at Marriott Hotel, Ikeja, on the 4th of December, 2025. The biannual conference of Association of Public Health Physicians, Lagos chapter, held on the 3rd and 4th of December 2025 at Marriott Hotel. The conference themed Global Health Under Threat, Advancing Sustainable Financing and Workforce Capacity for Equitable Healthcare Delivery in Global South, with sub-themes Rethinking Health Sector Investment, a call for paradigm shift towards equitable and sustainable approaches, innovations in health system strengthening, leveraging digital health, telemedicine, and artificial intelligence to bridge operational gaps in Nigeria. And the other theme, postgraduate fellows program and the gains for the health sector, redefining the role of the public health physician. The chairman of the association, Professor Y.A. Koyinu, gave the welcome address and highlighted the relevance and timeliness of the conference theme. She described the event as a platform for sharing solutions, developing practical strategies, and addressing complex health system challenges. The chairman of the conference, Professor Akin Oshibogun, also gave an opening remark. Likewise, the chairman of the conference organizing committee in person of Dr. Alex Oko. The conference was graced by several dignitaries, including the First Lady of Lagos State, Dr. Mrs. Claudiana Ibijoke Sanwo-Olu, who was ably represented by Mrs. Mustafa. We had the Special Advisor to the Governor on Health, Dr. Kemi Ogunyemi, who was also represented. We had several dignitaries, the permanent secretaries of the health districts. We had the SSA on Health, Dr. Tony Adeyemi, the chairman of the occasion himself, Professor Akin Oshibogun, the keynote speaker, Professor Adeshegun Fatisi. So, the keynote presenters at the conference included Professor Adeshegun Fatisi, who spoke on the main theme of the conference. Other speakers were Professor Akin Oshibogun, Dr. Solomon Oyetoyan, the Director of Medical Services and Disease Control for Health District 1. We also had Dr. Shola Kweto, the Permanent Secretary of Health District 1, Dr. Zamba, Permanent Secretary of LASHMA, who was represented by Ms. Toro, Adetoro, Dr. Jade Salah Idowu for Axel Mansard, Dr. Injude Indili, who was represented by Mr. Sunday. We had 3 plenary sessions, and then the highlights are as follows. For the first session, we spoke on monitoring and evaluation of digital innovations in Health District 1. We looked at the farmers' use of digital technology in hospital accreditation, Oncopadi's technology-driven cancer care interventions, the cultural and social barriers to digital tool adoption and telemedicine regulation, patient safety, data protection, and privacy. For the second plenary session, we had discussions on expanding the role and importance of public health physicians in Nigeria, skills in epidemiology, health management, and system-level policy development. We also identified gaps in training, talked about health financing, budgeting, resource allocation, soft skills, and relational abilities of public health physicians, and other relevance of the public health physician. For the third plenary session, it was tailored on sustaining health insurance enrollment, which requires continuous public awareness, simplified registration processes, and mechanisms that ensure coverage of indigent populations. Also discussed were major barriers to expanding access to health, with issues of poor interoperability of health systems, limited political will, inadequate financing for private facilities, and weak trust among practitioners. We had goodwill messages from Dr. Bimbola Bowale, the Permanent Secretary of Health District 5, Dr. Noiga, Chairman, Health Service Commission, Dr. Shalak Quinton, Permanent Secretary, Health District 1, Dr. Femi Omololu, Permanent Secretary, Health District 5, Health District 6, Dr. Dapo Ashiobi, Permanent Secretary, Health District 5, Dr. Lajide, Permanent Secretary, Health District 3, Dr. Tony Adeyemi, the Senior Special Assistant to Health, Lagos State. The conference had 25 abstract presentations, of which 10 were for oral and the others for poster. The 3 best oral presentations and 3 best abstract presentations were awarded. The challenges that were identified during this conference: 1, health financing and coverage challenges. Part of the challenges noted includes the issue of high out-of-pocket expenditure, stating that over 70% of Nigerians pay directly for health. There's low national health coverage of insurance. Less than 20% of Nigerians are still insured. We have fragmented and reactive financing structures. We have insufficient financial protection for vulnerable groups, difficulty assessing sustainable financing, especially for private facilities. Other challenges are the healthcare system structural challenge, with weak public-private coordination and limited synergy in the healthcare ecosystem. Investments heavily focused on infrastructure rather than systems, quality, or outcomes. Poorly integrated health systems that do not speak to each other and functioning in silos. We have workforce shortage and migration, the popular brain drain, with underfunding of health providers. Still on the challenges noted in the conference, digital health and interoperability challenges, which include fragmented digital tools that operate in silos, lack of strong political will to fund and enforce this interoperability, absence of a unified national digital health framework, limited data sharing among the health management organization providers and government systems. We also have economic and social challenges, and of significance is the rising household poverty. 52 to 56% of Nigerians live below the poverty line. We have issues of catastrophic health expenditure, increasing especially post-COVID. General economic decline impacting healthcare costs and purchasing power. We have difficulty assessing capital healthcare business due to high financial risk. Furthermore, we talked about the trust, governance, and accountability challenges. It was stated that there is lack of trust among healthcare practitioners, making partnership difficult, limited transparency, and accountability. There's weak governance structures affecting financing, regulation, and service delivery. As it was stated, the issue is not in policies, but is actually in the implementation of these policies. We also talked about access and equity challenges with a large rural population, over 70% having limited access to insurance and healthcare services. We have vulnerable groups like women, children, disproportionately affected. There's insufficiency primary care investment with limited telehealth and remote care infrastructure outside of urban centers. Looking at the challenge in capacity and literacy, healthcare workers often lack financial literacy needed to engage with investors and lenders, with insufficient training and upskilling of the health workforce and limited managerial capacity across many health facilities. And the last challenge highlighted is the challenge with foreign aids, which includes the fact that the government oftentimes would now leave their responsibility to sponsor health, and then we now have a lot of donor dependence. For the recommendations and the targeted audience, which I will expect us to please pay keen attention. So we're proposing these recommendations to the government, basically all tiers of government. First of all, we're looking at 1, let's invest in the well-being of people, emphasis on social determinants of health and security. We're proposing that the government should prioritize primary care, data-driven oversight, and system-wide integration. We're also looking at the government helping to improve workforce stability and capacity building beyond short-term trainings. Syntaxes on products linked to chronic illnesses such as tobacco and sugar should not be shared across sectors, but rather this syntaxes should be solely invested into the healthcare sector, which is the sector that triggered these taxes in the first place. Part of our recommendations also include to strengthen sustainable health financing and system reliance through, one, increase domestic health funding to improve efficiency and accountability and expand innovation, financing, and PPPs. We're also proposing that the government should align development assistance with national priorities, reduce fragmentation, and integrate donor programs into long-term health strengthening. We also hope that there will be prioritization of a strong primary health care system, prevention, surveillance, and emergency preparedness to build a resilient and responsive health system. We're also hoping that we could expand and empower a people-centered health workforce and community system, and a scale-up of health workforce production with strong STEM foundations, quality training, and technology-enabled education. To the government as well, we're hoping that they will improve motivation, remuneration, and retention while ensuring effective regulation of healthcare workforce. We're also hoping that it will strengthen the community ownership, engagement, transparency, and exclusive decision-making to build trust and deliver people-centered care. To the Lagos State Ministry of Health, our recommendation goes thus. One, the Lagos State Ministry of Health should please look into establishing Lagos Public Health Systematic Review and Evidence Hub. This is to conduct priority reviews, support evidence-based policies, and strengthen capacity. This proposed hub would conduct priority reviews for the state. It will strengthen evidence-based policy making and build local capacity in evidence appraisal. The funding for this hub may be domiciled with the Lagos State Ministry of Health. We're also hoping that Lagos State Ministry of Health will invest in primary healthcare digital innovations, telemedicine regulation, and infrastructure upgrades. To the medical education authorities, referring to the MDCN, our postgraduate colleges, and NUC, we're proposing, or recommending rather, that they should recognize the fellowship program as sufficient postdoctoral qualification. We're also hoping that it will provide incentives, support recruitment, and reduce the workload of healthcare workers to mitigate the brain drain issue. We're also hoping that it will enhance residency training with exposure to health financing, resource allocation, and policy development. Furthermore, in our recommendations to public health practitioners and other public health institutions, we're hoping that you'll adopt and scale digital health innovations for improved service delivery. We're hoping that you will improve monitoring, evaluation, and data-driven decision-making. Still to the public health practitioners, we're hoping that you also strengthen community engagement to overcome cultural barriers in technology adoption. To the academia and research institutions, we recommend that you support AI and digital health interventions for public health education and prevention. Conduct systematic reviews to guide policy and program development. To private health sectors and the HMOs, we recommend that you please move from small cottage hospital concept to bigger hospital chains with consideration for mergers and acquisitions to expand health service provision. Also kindly look into integrated data platforms with NHRA, interoperability to enable enrollment data exchange among the HMOs, the hospitals, and other healthcare providers. With this, I have come to the end of our communique, so we would like to listen to your comments, suggestions. Are there things that we have left out, things that we need to fine-tune, or things that we need to totally remove from the communique before it is released? Thank you very much for your rapt attention despite the lunch. So, I guess I will anchor this session myself as the MC is presently unavailable. So I don't know if in the audience we have anyone who has any comments. Okay, so one, yes, ma'am. Do we have any other person that has a comment, a contribution? All right, so in the absence of that, we'll take Dr. Olufunlayo. Thank you, ma'am.
Thank you very much, Dr. Ogunyemi. I want to commend you and your team for such a detailed communique and released, immediately at the end of the conference. It shows that you've been working hard all through. Well done to you. First of all, about those present, I think it's important to say, you didn't mention the Commissioner for Health being represented and the essay to the Governor on Health being represented. You might have just missed it out while reading it, but please, we must make sure we mention that they were part of the program. I also want to point out that you spoke about increasing the production of health workforce. And I know that the keynote speaker emphasized that it should not be done, or it should be done without compromising quality. So I think we need to put that in there. For digital innovations, you mentioned it twice, but the first time you said they should adopt digital innovations. I think it's important to make reference to the fact that some digital innovations have already been started and those can be scaled up while we adopt others, such as the one presented in yesterday's panel, because I think that's really a prototype that we can look at to adopt. And then when you were talking about the fellowship, I think the recommendation is more for the employers post-fellowship and not for the accrediting body, if I got you right. So it is, we are looking at working at first with Lagos State, and we had said we were going to see the PS of the Health Service Commission at secondary level, which is where we are having a major issue. And then from there, maybe if we have developed a prototype, we can escalate or expand nationally. Thank you. Those are my observations. But once again, very well done. Thank you.
Thank you very much, ma'am, for paying rapt attention and for the comments. They are duly noted, and my team will work on that. Thank you. Do we have any other comments, contributions, questions? None. All right. So please permit me to recognize my team members. This is not a job that has been done by Dr. Ogunyemi alone. Would my team members please kindly stand up for recognition? Please stand up for recognition, the rapporteur for this conference. Please kindly stand up for recognition. Thank you very much. I have Dr. Adeserano to my right here, followed by Dr. Tagwai, Dr. Odufua, and the gentleman in our midst, Dr. Iluyomade. Thank you so much. I couldn't have done this without you. Thank you.
Bon appetit, everyone. Sorry to interrupt your lunch, but we actually haven't presented the Best Poster Award certificates. Professor Akinka, they're here. So if the recipients are here, Professor Dr. Fadare. With oral.
Good afternoon, everyone. Good afternoon, everyone. I know our mouths are busy. Okay. So we're going to present the certificates to the best presenters. And I want to invite Professor Shibogunsa. Okay, so please can Dr. Chima Oduko come up for the third place for oral presentations. So this is our own.
Anire, congratulations. I'm excited that you are making progress. So here is your certificate. Fua, glory. Glory Fua. Wow. Wow. Well, Glory Fua is a medical student from what I learned. So she's going to go places. Congratulations. And the winner is
Okay, so distinguished ladies and gentlemen, in third place for the best abstract presentation, poster presentation is Chima Oduko Anire. Put your hands together for her. She won the oral third place, and then she's winning the poster third place as well. Congratulations. Oh, okay. So in second place, we have NIDSG NIM Foundation, University of Abuja Teaching Hospital Partnership. Put your hands together. Represented by our very own chairperson of the LOC, no other than our delectable Dr. Mrs. Morenike Alex Oko.
No. Okay. Done. Thank you.
Congratulations. Very interesting. And in very first place for poster presentation is no other person than our Akinlawo Damilola. Woo! Congratulations and well done. He's done so much for this conference. All right. Congratulations once again to all
Members of the LOC, please step forward quickly, please. All members of the LOC, please step forward. Dr. Mosu, Dr. Johnson, Dr. Fadare, Dr. Drojaye, Dr. Ukatu, Dr. Dusholu, Ichili, Dr. Babalola, and Dr. Chai. Oh yeah. The chairman, Aphpn Lagos State Chapter, Professor Yetunde Kuyinu, and on behalf of the local organizing committee for Aphpn 2025, I want to say thank you to everyone that has been a part of this conference. We want to especially thank our sponsors. You've seen them all on the display board outside. We want to thank Investment One, Apple Group. We want to thank Sunfit International, Sepster 7, Techno Oil, Chris Gloria, and a host of others. It's a very long list. We have about 21 people who sponsored this event. Please give them a round of applause. We thank them for their support to the advancement of public health. There is no way we would have been able to have done this without them. And of course, we wouldn't be here without the grace of the Almighty God, to whom we return all the glory. And I want you to know that in the process of this planning, I discovered many prayer warriors, pastors in hiding, part of the untapped potential we're talking about. Please give them a round of applause. And a round of applause for God Almighty as well. Please give God a round of applause, so that He can bring us back here in 2 years. We give Him praise and glory. Thank you very much. Thank you. Thank you. Thank you. And that is my task, and that constitutes my closing remarks. Thank you again. Yes, I hope we all heard the communique, be it far from me, to begin to repeat everything that Dr. Rike said. You will see it on YouTube. It will be printed, and so I can release you from
listening to all of that again. Thank you very much.